Are we live now?
No, he'll not count down.
So you are live now.
Yeah. Can I start? Okay. Very good afternoon to one and all of you, all the expert panel and the great array of speakers we have for this ARC bouquet, video bouquet of cataract challenges. Believe me, the next 3 hours is going to be having you all glued to your seats, and at the end of it, all of us would know that we have learned a lot, and I'm sure our delegates would feel the same. So just stay connected right through so that I'm able to take your inputs as and when you want to add on to. And we shall now go on to introduce our expert panel. Dr. Ramurthy is there with us. He's our chairman of the Eye Foundation Group of Hospitals and also a past president AIOS, and has been always a great teacher, and it's a great pleasure to have him on with us. Dr. Rohit Om Prakash is another great individual who needs no introduction, and he's again heads the Rohit Om Prakash Eye Institute from Amritsar, and he's so famous for his winter IRSI, which he looks into 6 months in ahead and a very meticulously run program. In fact, I would say he's actively involved in the phacoemulsification education program of the country for more than 20 years. We would have Dr. Rajesh Sinha joining us soon, who's a professor of ophthalmology, specialized in cataract, cornea, and refractive services from RP Center, and is also our honorary treasurer and has done a great job in the COVID times. Joining us soon would be Dr. Gopal Raju, the chairman of the Vishaka Eye Hospital, Visakhapatnam, and is also the chairman scientific committee of the AIOS. Dr. Ragni Parikh could not join us, and it's because she's not been keeping well, and it's our ill. Joining us soon would be Dr. Gaurav Luthra, who's again the director of the Drishti Eye Institute and is also the chairman IRSI and a very versatile cataract refractive surgeon. And moderating with me, although Harshul again has a very important music program in Jaipur, and he needs no introduction. He heads his hospital and is a very energetic and active member ARC from the central zone, and is not just an amazing surgeon as we're going to be seeing his surgery, but he's also one who has his finger into everything, be it games, being tennis, be it anything, badminton, or probably, and music in a big way. And he's taken life beyond ophthalmology to an entirely different level. I do hope you're able to stay with us for some time. A small change in the sequence of speakers would occur, but largely all of them would be there in the sequence mentioned in the flyer. We shall now go on to our first speaker.
Ma'am, can I share Entod video?
Yeah, you could share the Entod video. Yeah. We owe to Entod for sponsoring all our ARC webinars in the last 2 odd years. And it is, let's watch it. Thank you very much. We shall now go on to our first speaker, Dr. Shubhra Goswami, who's the Managing Director of the Nalbari Eye Hospital and Site First from Guwahati. And he has a very interesting video to showcase to us. On to you, Dr. Shubhra.
I'll be sharing the video, Dr.
Yes, you'll be sharing the video. Yeah.
Shall we start, Dr. Shubhra? You're muted, sir. Dr. Shubhra, you're muted.
Dr. Shubhra, I think you're muted. Yes.
Shall I share the video, sir?
Yes.
Yeah, please share the video, please. So this is a rock hard cataract without having any cortical cushion. We'll do phacoemulsification with a different technique. This viscoelastic we are injecting. Now we'll do the axis which is slightly bigger in size, such that we can reduce the stress on the granule. Just doing the hydro, but here we are doing a hydro. See the blackness of the whole nucleus. Now we are not doing much rotation because that might give the stress on the granule. So now we are doing a crater. We are trying to reduce the size of the nucleus from grade 6 to grade 3. We are just doing a crater. Central part of the nucleus we are just reducing the size. Separating the very hard thick nucleus. We are giving very care for reducing the stress on the granule and removing the hard, very hard leathery nuclear part. See again the blackness, the hardness and leathery nucleus. Care has been taken to reduce the chatter of the inside the AC because this sharp nuclear pieces might hit the posterior capsule. Then the cortical matter being removed. This is nothing new. Just enlarging the main port. And injecting a Acrysoft single piece IOL. Nothing new now. The whole idea of this surgical procedure is to reduce the stress on the granule, number one. Number two, to reduce the size of the nucleus such that we can use less power and it is for nuclear separation. We are injecting Vigamox intracameral. Routinely we are doing. Air bubble size is slightly bigger, that's why we are just removing the air bubble size and finishing the surgery with 6/6 vision next day. Thank you very much.
Thank you very much, doctor. That was a challenging surgery which you have shown. I would want to take a question with both Dr. Rohit and Dr. Ramurthy on this. Dr. Rohit, how much of the ultrasound would you want to be torsional, and when would you want the longitudinal component to come for a play in it? And what are your thoughts on creating a crater like he did, or would you want to go ahead and do a chop or quadrant? I know these are all techniques which is each person is comfortable with and would go along with it, but your thoughts on the phaco component of it.
Yeah, I think I would like to congratulate sir for coming out with such an excellent display in such a hard cataract. As we are all aware, as he has rightly said, he made, all the steps were meticulously done. He created a large rexus. He stained the capsule because he didn't want the chopper to hit the, rexus edge and create a situation where there would be an extension to the periphery. Your first question was that
How much of torsional and longitudinal
should be the longitudinal exclusively used? Well, if you want to hold it, then you should be using the longitudinal, because I'm usually I do a direct chop, and when I'm initiating the direct chop, that is the time when I use the longitudinal only. But when the chopping and every other things or the aspiration comes, then I use IP of say 90, wherein the torsional is there, and just to emulsify in a smoother wear, the longitudinal comes into play. His is a beautiful idea of creating a crater in the center because all these nucleus in the hard black cataracts, they are 4.5 to 5 millimeter at times. So you have to debulk them as he rightly did. And I think it was spot on how he did. And smaller pieces, totally separated, replenishing the AC with the viscoat or viscodispersive to all these points, should be, and he did it meticulously. This is both second part.
Dr. Ramurthy, you want to add anything different to what was said?
I think it was a very beautiful demonstration in a tough case, and Rohit mentioned many of the points which come to my mind. I also use only longitudinal phaco for phaco chop during the chopping, because I think that gives me a better hold on the meat of the nucleus. And once it comes to fragment evacuation, I switch over to purely torsional phaco. And even for these hard cataracts, I just use about 70% power with the IP on, which tends to bring the fragments onto the phaco tip in the right manner. He did use a central crater to debulk the nucleus, and which worked very well for him. But I do a slightly different technique in the sense that I use a mini trench right from the rexus margin, the subincisional area, to the center of the nucleus. And this not only reduces the volume of the nucleus, which is less of a importance to me, but gives me access to the meat of the nucleus. In these hard cataracts, it's a good idea to expose your tip a little longer, have a new tip, it's a sharp tip. I'm talking about phaco needle tip, and then bury that adequately. And once I create this small crater, and then I'm able to get better access to the meat of the nucleus, get a firm hold on it, and then come over to phaco position 2 and go ahead and fragment the nucleus and complete the evacuation.
Yeah.
So it is well demonstrated. I think only one other point I would do is, apart from frequent use of dispersive viscoelastic, use the chopper to protect the endothelium from the nuclear fragments which are flying around and hitting the back of the endothelium to the extent possible. And usually it's a good idea to sub-chop the entire nucleus within the bag. Invariably, when you're removing the nucleus fragments, the fragments do have a tendency to come into the anterior chamber. So generally, I dip it down so that the emulsification is happening at the posterior plane. And I also use the chopper in such a way that the nucleus fragment, which is brought up one by one, has a less of a tendency to come and hit the endothelium.
Yeah. Of course, Ramurthy has also discussed about the tip configuration and that we need to expose enough of the tip to get a better purchase into the fragment, and also the cutting efficiency of the modern phaco machines. The tips are really remarkable. I want a comment from you, Dr. Rohit, about this dispersive viscoelastic. How you think it could create a wound burn?
Yeah, wound burn, wound burn is only created, when you are starting with these, in the initial stages, when you're using more energy, say, especially in these 2.2 millimeter, incisions. At times, the visco comes in clots.
Yes.
So you have to irrigate it and you have to gradually get into this thing. Yes. So wound burn is something, initial 5, 7, 10 seconds, you have to be very sure, because that is the time when phaco burn does occur in these patients, wherein you are trying to use high energy right from the first floor.
Yeah. It's important that you have adequate flow so that the visco doesn't come and clog the aspiration port.
I just want to make a point here. I use a slightly different technique to avoid this. The sense that dispersive viscoelastic does have is thermogenic, and if you straight away go on to foot position number 3, then that's one situation where you get an wound burn. So usually you're supposed to evacuate a little bit of viscoelastic and then go on with the phaco. I do a slightly modified way of soft shell technique, in the sense that I use a coating of a dispersive viscoelastic on the corneal endothelium, and then subsequently inject a little bit of HPMC in the center, so that when I initiate my initial phaco, it's in a font of HPMC, and the endothelium as such is protected by a coating of the dispersive viscoelastic. And I find that with this slight modification, especially in step 2, when I'm removing hard nuclear cataract pieces, the propensity for wound burn is significantly reduced.
Now, when we are supposing you were to do this in a femto cataract platform, naturally it goes without saying that we need to create more grid pattern and chops and all that has to be done. But there is a lot of cavitation bubbles which also get created. Could you all have a tip for that, so that there is not a experience of a capsule blowout? I know it hardly ever happens, but any tip you would have? Dr. Rohit, you want to say something, Dr. Ramurthy?
Yeah. I think before going into that, whenever my basic concept of, whenever we have had blowout fractures whenever if you go through the literature, those were through only with the posterior polar cataracts. It happened. So those blowout fractures happened with that. My rule of the thumb is that whenever I cannot see the posterior capsule, even when I'm using a retroillumination, I do not do hydrodissection. I believe that all cases wherein you cannot see, you should not do hydrodissection. If you have to do, it should not be a vigorous hydrodissection. So this is something which should be borne in.
Dr. Harshul, you want to add anything here?
No, I think everything has been said by Dr. Ramamurthy sir and Rohit Prakash sir. Of course, I also use the same technique, drill and chop, which I described in 2010. So basically, I try to create a central hole in which is very deep and which is further away from the rexis, almost 2 millimeter, that hole. So that, of course, as Ramu sir said, we get a good purchase there in the substance of the nucleus, and we also get a proper depth to chop, so that our chop becomes more effective, and it's it's very safe in the center. It's well away from the rexis margin. So that's how you need to do, divide it into smaller pieces and take care that you coat the endothelium well with the dispersive viscoelastic and all those things.
Has any experience, Harshul or Dr. Rohit, have any of you all used MyLoop in these kind of hard cataract when there is also no epinucleus cushion is there? Any idea, anybody?
I never used.
MyLoop is an excellent concept.
Yes.
But I have only one reservation for that.
Yeah.
Because if I have to do in a black cataract, as sir demonstrated, the most important thing is we need to have smaller pieces. With MyLoop, you cannot have more than 4 nuclear fragments. So because a large nuclear fragment, when it comes into the anterior chamber, no doubt as Dr. Ramamurthy sir said, that you use chopper as a shield to protect it from the endothelium. No second thought about it, but still with 4 big nuclear quadrants, I really do not buy the idea. Till the time we have a provision wherein you can create 6 or 8 nuclear fragments, I would definitely not go in for a MyLoop one. Dr. Ramamurthy sir, your comments on this?
Yeah, I completely agree with you, Rohit. Frankly, I have no personal experience with the MyLoop, so I cannot really say it's bad. But somehow, when you have access to a good femtosecond platform and modern phaco machines, I really don't know whether it has a huge role to play. And when there is, especially in these very hard cataracts, when the capsular bag itself is a little tremulous, there is very little space. At least for the initial few cases, it might be a little difficult to maneuver that. But having said that, there are surgeons who feel that it's a significant addition. But I agree with all the points that you said. And I am sure there will be some youngsters who will be tuning and listening. So just for you to know that, chopping is not the only way to go with these heart cataracts. One of the reasons I do this initial trench from the subincisional area to the center of the nucleus is sometimes the cataract is so hard or leathery that I don't get a through and through chop where the nucleus is split into two complete halves. In that case, after a couple of tries of burying the nucleus and into the nucleus at a deeper level, if I'm not able to chop, I just go ahead and trench that and make it a stop and chop, convert that into a central this thing and create a groove as deeply as possible, then go in with two Sinskey hooks in the depth of the nucleus and just split it up with this lateral separation, causing a minimum amount of stress in the capsular bag. And as regards Chitra's question about the use of the femtosecond platform, only thing you need to remember is that usually with these hard cataract, we use very small cubes, and that creates a lot of pneumodissection and bubble formation. So extra vigorous hydrodissection should be avoided. You press down on the nucleus so that the air bubbles come out, and then give small aliquots of fluids and rotate the nucleus in a more gradual manner.
Thank you very much, Dr. Goswami. That was a wonderful video we saw. Do stay connected with us. We shall now go on to Dr. Harshul, who's going to be showing us another very challenging situation. On to you, Harshul.
Yeah, thank you so much, ma'am, for. So I'll be sharing a case of traumatic cataract. Can you see my screen, ma'am?
Yes. Yeah.
Okay. So this was the case, and this was a 28 years old male who came with this traumatic cataract, and along with that, he had a mydriasis here, traumatic mydriasis. So his pupil also needed some, something to be done here. You can see that the corneal tear repair, which was done, I think 6 or 7 years back. So the plan was to, of course, be ready with whatever zonal dialysis or whatever we encounter, if it's there, and do pupilloplasty also along with doing the cataract surgery. So make a limbal incision here. This is a clear corneal incision. It's a 1.8 millimeter incision. Stain the anterior capsule and start the capsulorhexis. So when you are doing capsulorhexis, you get to know that what is the status of the zonules. So here you can see that the rhexis is proceeding as it's needed. And so once the capsulorhexis is done, I just go ahead and trying to take this soft cataract, but I realize that it's not that soft. So I go ahead and chop this nucleus. I was very much careful that there may be a post-capsule rupture, because you never know, in traumatic cataract you may encounter a PCR along with the cataract. So all your maneuvers should be very meticulous and very gentle, and always try to maintain the anterior chamber so that even if there is a PCR, you don't extend that PCR. So luckily there was no PCR there, and this cataract was taken off to do bimanual irrigation aspiration. And once that's done, I put a single piece foldable IOL in the capsular bag, and after putting IOL, I realized that rhexis was a little smaller. So I go ahead and give a snip here and enlarge the capsulorhexis to desired size. And after that, now the time comes to do pupilloplasty. So I stretch the pupil, this iris margin from both the sides here, so that put some myocol. Now I take a 90 proline suture. So for pupilloplasty, you go from this main incision here and hold the iris tissue with the iris forceps and give a stab incision from the limbus. so that you pass this needle through this iris, proximal iris here. And once you pass from this side, then you go ahead and I use a 30 gauge needle to railroad from this distal iris here, and you take this needle out. And after taking this needle out, you need to take this loop from the proximal iris here and take this loop out. So this is a single pass 4-through pupilloplasty, which has been taught by Dr. Amar Agrawal. It's a wonderful technique to do pupilloplasty in such cases. Then after that, you give 4 throws here. You just give 4 throws, you count them, and once you do 4 throws, you just pull both the ends and your job is done. So I just pull both the ends and tighten it. So after that, I realized that it needs one more here. So you go ahead and you can give one more knot here. And this. And after that, you again pull and your work is done. So you go ahead and hydro stitch all the incisions and your job is done. Thank you so much.
Yes, as always, you are amazing with your videos, Harshul. So I'm going to ask you some questions here. Supposing the iris defect had been larger, what would your approach have been in that case? And when would you consider using partial iris segments also?
Yeah, I think that's the case when you need to use partial iris segment. If the defect is very large, in that time you may need that.
Yeah,
so
you had
pupilloplasty is not. Yeah, so pupilloplasty is not possible.
Pressurize it, whatever way I will try. Okay, I convince him little bit.
I think.
So,
yeah.
Yes, ma'am.
And did you do a hydro in your case?
Hydro dissection?
Yes.
No, I didn't do.
So that is another important message in a traumatic cataract. If you have not done an AIOS-ARC and you have not confirmed about whether the capsule is intact, probably it makes sense to not do a hydro because you don't know about the status of the posterior capsule. And of course, it was a very small area of iridodialysis you had, Harshul, so it could be ignored. But supposing there was a large area of iridodialysis and also mydriasis, how would you combine both pupilloplasty and that? Because it is actually in opposite directions.
Yeah. So then you need to do iridodialysis repair along with pupilloplasty. Yeah. So that's a wonderful technique shown by, that's a swing needle technique. I think that technique works very well. I use that technique wherever I need to do iridodialysis repair. And for pupilloplasty, SFT works wonders, I guess, So once we have,
Dr. Rohit, do you have anything to ask? Dr. Ramurthy, anything to ask? Because it was such a beautiful self-explanatory video. I had to just hunt up some question to complete it.
I think Dr. Harshul is a rare talent.
Yeah.
He just shows that if you are good in one thing, you have to be good in everything.
Yeah.
And that's something he has. That, and Dr. Harshul, one question. There was corneal suturing also done in this patient, as you said initially, because of the trauma.
Yes. So this patient has history of trauma almost 6 years back. So when he came with this cataract, I was also surprised. I asked him, why didn't you go for cataract surgery for so long? Means this cataract must have been there for like 1 year, 2 year maybe, But he said, yeah, we didn't go for surgery. So I was also not sure that, what we're going to achieve. But surprisingly, this patient had very good vision and everything went off very well.
I think the only thing, yes, if there is an associated astigmatism in high astigmatism, then pinhole pupilloplasty could have been,
yes,
been added. But since it was quite a bit of off center, and as you said, maybe the astigmatism was not profound. And what was the zonular status in the area in which
it was good. You saw when I made X-rays, everything was perfect. There was no zonular instability. the capsular, yeah, it was perfect.
Yeah, so the one more
So
thing.
in traumatic cataract, we all know that we have to be prepared for everything, you know.
Yeah.
So intraoperative, we may encounter anything. There may be zonular instability, weakness. We may need CTR, CTS. So we should be ready with everything.
Yeah.
But luckily, in this case, there was nothing like that.
Yeah, one and the additional thing which could have been tried is that that area where the iris was absent, the trypan view could have gone behind also. So the use of trypan view, if we can make it more judicious, the use of trypan view, that will not spill into the posterior segment and that will not impede the visualization.
Yes.
So one trick which at times we can do is we can instill some visco in that area, which
Yes.
blocks it, and then you can add trypan view, not in a phased way. And I think it was perfectly done. Nothing more
Yes.
can be said.
Ramurthy, shall I go on to the next video?
Oh, superb demonstration, textbook demonstration as well. Congratulations.
Thank you,
I
sir.
just have a comment to make. I think it was already referred to. The sense I personally thought that the defect was fairly large. Sometimes in these situations, what happens is that you are able to approximate the pupillary margin, but peripheral to the area of approximation, there is a fairly large defect that's still visible. In these cases, now because we have got that, thanks to Amar, we are all becoming familiar with these procedures, and iris prosthesis is becoming available in India too. And in these situations, putting in iris prosthesis may be a good idea, because even though you are able to approximate the pupillary margin, sometimes peripheral to that there is a large area of defect. Because I remember this, ICL patient of mine, before the central flow came into being, inadvertently I had created a slightly larger pupillotomy. And that patient was, in spite of the fact that it was in the periphery, kept complaining about diplopia and the quality of vision being quite bad. It was quite a difficult situation to handle. So in these cases, maybe a prosthesis might be a better.
Yeah. So in this case, I didn't go for the third pass of SFT because there was a corneal scarring in that area, which I thought, which is already obscuring that part. You're right. Of course, if that area is large, you need to cover it with processes. Yeah.
Absolutely.
Thank you. Actually, I just wanted to add one thing. After Dr. Kashyap, I would want Dr. Thomas's video also to run, because I have created the questions combined for both of them, because it is partly related to the posterior segment part of it also. So after that, we will go back to the regular sequence of cases. So on to you, Dr. Kashyap. We could go to you. Thanks a lot, Harshul, for your amazing video.
Thank you.
Dr. Anand, could you share his video?
Yeah.
Just a second, ma'am. Just a second. One of the
I start my video?
Okay, you will start? Okay, go ahead.
Please start. Sir.
Okay, please start.
Please.
We will take questions after both the videos are played.
This is a case of traumatic cataract subluxated with iododialysis and high IOP with vitreous hemorrhage. After irrigating lifeline maintained, scleral wound made, corneal wound made little more vertically. A 26 gauge needle passed through the scleral wound and balance from corneal wound passed. Taken a bite of the iris and with railroad technique, the needle was brought out. Repeated visco was injected for safety of passing the needle without hurting the cataract and vitreous and cornea. 90 Allen's needle was bent after measuring the white to white width and needle holder checked for any slippage chance of needle while doing maneuver. It is the iris bite being taken. Now, while tying the knot, I found that there is a micro tag of the cornea. So I did this zigzag movement to cut the micro tag. And this partial repair of the iodinalysis helped me to visualize better. And rexes were done with the help of needle and forceps, avoiding any more stress on the subluxated side. Preoperative B scan showed a very dense vitreous debris with attached retina. So putting the IOL would depend on catheter distance, nucleus drop, and conditions of posterior segment. Decided not to put the catheter hook. Gentle hydrodissection was done. Very gentle one. And phaco started. Nucleus was not as soft as I had judged. So I thought to deliver the nucleus out of the capsule without putting any stress on the already dehisced area. So emulsified the nucleus. The remaining part of the dialysis was repaired after this. Endolight showed after this, this time I was more careful not to have any tag of the cornea. Endolight showed a dense vitreous hemorrhage. Vitrectomy with the Centurion itself, no financial interest, was done with irrigating contact lens. And I found few tags of the vitreous in the corneal area, corneal incision area, which was cleared from the corneal road. Further vitrectomy was done. Before closing, I injected Tricot for anti-inflammatory actions. Air injected. And close all the wounds. And this 7 days post-op, clear cornea, vision 6/12 with corrective glasses in the dilated pupil, and the fundus is normal. That's all. Thank you.
Thank you very much, Dr. Kashyap. That was a challenging video. Of course, you have not implanted the lens. It was to be done in a next sitting.
Yes, ma'am.
Okay. So just stay connected. I would ask, introduce Dr. I forgot to introduce you. I'm so sorry. I just went on straight to you. I think Dr. Kashyap has shown us a great video and he needs no introduction. And he heads the Kashyap Memorial Hospital from Jharkhand. And we are truly enlightened to have him with us today. And next to go would be Dr. Thomas Cherian, who's again a senior consultant, a very popular figure in Kerala. From Little Flower Hospital and Research Center. And he has another interesting video to show us. And then we would take some combined questions. On to you, Dr. Thomas.
Shall I share the video, Dr. Thomas, for you?
Yes, please.
Just give me a second, sir.
Good afternoon. This is a case where a cataract surgery was done elsewhere and there was a nucleus drop. The entire nucleus had dropped into the vitreous cavity and the patient came with the nucleus in the vitreous cavity. Here is the eye with the nucleus drop. Here I am putting a 3-port 23 gauge sclerotomy. In a case where a cataract surgery has been done recently, we have to make sure that we use a fresh trocar cannula, otherwise the cataract wound might give way. Here we use a trocar cannula system, a 3-port sclerotomy, then we do a vitrectomy, and then we put a 20 gauge incision for the fragmentome, and we complete the nucleus, nucleus removal with ultrasonic fragmentome. After that, we have the SFIOL. Here, a marking is done on in the superior and inferior limbus, so that the SFIOL, once it's positioned, it positions vertically, superiorly and inferiorly. Here we make a conjunctival flap. It's marked properly on the cornea for the vertical and the horizontal meridians. The scleral flap is made. A partial thickness scleral flap is made, and the flaps are lifted. We cauterize and make a hole in the sclera in the deeper flap. Then we pass the sutures through the flap. Now we make a scleral tunnel incision temporarily for inserting the IOL. The scleral tunnel incision is meticulously made. An opening is completed in the deeper layer of the sclera. Yeah, that's how we make the opening in the deeper layer of the sclera. Make sure it is perforating well through and through. Now we introduce the intraocular lens, which has already been positioned with the sutures. We have pre-placed sutures on the intraocular lens before we introduce it into the eye. And once the lens is introduced, we have to position it very meticulously so that it's well centered. The haptics are brought superiorly and inferiorly. Yeah, that's how we position it. The haptics are brought superiorly and inferiorly, and the sutures are brought out. The sutures are tied taut enough so that the lens is stable behind the iris in the position where a PCIOL should usually sit comfortably. After suturing or after tying the knots and making sure that the lens is in good position, we put back the scleral flaps. Here the lens is well centered. The scleral flap is put back with the glue and the flap is back in position. Now the conjunctiva is put back and there is a well centered scleral fixated IOL. Thank you.
Thank you very much, Dr. Cherian. I think there are certain basic things which all of us do know, that if it's a very hard nucleus in the vitreous, a fragmentome is used. Otherwise, you could use a vitrectomy cutter if it's just an epinucleus fragment. But all of us also know that we need to do induce a PVD and do a complete vitrectomy, and then only go on to removing of the nuclear fragment, which is done by our retina surgeons. So to be relevant to the anterior segment surgeons, Dr. Rohit, I wanted to ask you, or Dr. Ramurthy, when is a situation in a nucleus drop wherein you would hesitate about placing a lens in the same sitting? Like Dr. Kashyap had not placed a lens in the same sitting. What would hold you back?
I think there would not be, many conditions where I would hold myself back.
Yeah.
If possible, I'll glue the IOL, use a glued IOL technique. And if by any means you feel that the posterior segment is not, the prognosis is not good, that is the condition where I would not, use an intraocular lens in the first sitting.
Yeah.
And if by any means it's an undetected one, and if there's a PCR and there is a condition wherein, it would require handling with a long list, then I refer it to the posterior segment persons in the next OT for them to take over. Otherwise, yeah.
No, I think if there is a retinal break. Yeah, yes, Dr. Ramurthy, yes.
Oh, I just have a comment to make in the sense that, it also depends on the situation you are in. For example, Dr. Thomas is a very competent VR surgeon. So if I have a VR backup like that, even if it's a hard nucleus which has dropped down and a fragmentome is available, I'll go ahead and implant a lens.
Some work is going on, huh? Okay, sir. Yeah.
Please, could all of you mute yourself? Yeah.
Yeah. So if even if a hard nucleus has dropped down almost in its entirety, as in this case, I'd go ahead and implant a lens if it is either in the sulcus or wherever, whatever support system is possible, because I know the vitreoretinal surgeon with the fragmentome can do the evacuation in the vitreous cavity itself. But if it's in a situation where the fragmentome is not available, it's not universally available, and such a hard nucleus has to be brought in through the anterior incision, then obviously placing a lens is not a good idea, and the nucleus can be removed, and then the intraocular lens can be implanted in the same sitting. Other situation is, sometimes majority of our surgeries are done under topical anesthesia, and you have a situation like this, then my preferred choice for secondary implant in those cases is a iris clip implant, which can be implanted pretty quickly. But otherwise, if the patient is not cooperative, then and you are not very comfortable with the secondary implantation techniques, it might be a good idea to close the case at that point of time, and then go back again with in a more prepared frame of mind, and with a injection anesthesia, and then go ahead and implant the intraocular lens.
Yeah, essentially, I also wanted that if there is some posterior segment pathology which you realize while doing a vitrectomy, or if there's something like a suprachoroidal hemorrhages or a choroidal effusion, or if there is a lot of corneal edema is there, those are those extreme moments when it's okay for you to delay the implantation of the lens in the same sitting, and unless you have a great vitreoretinal backup who can beautifully take on and complete it. I think more the latter, the capability of the retina department in all our centers are so good that I think everything can be done at one go. Now, as far as Dr. Rohit, the question to you, as far as after a nucleus thing, how would you avoid breakage of the haptics when you are taking them out to do a glued IOL?
Sorry, I didn't get it.
How do you avoid breakage of haptics when you are doing a glued IOL?
So, you have to hold it right from the tip when you're trying to, bring it out. That is the first click. In this, when you're trying to glue it. And when you are trying to use the trailing haptic as it would go in, you can use the handshake technique for that matter, wherein you go as close to the haptic tip so that you don't break it.
Dr. Cherian, would you have some tips to add at this point?
Yeah.
Avoid breakage of haptics, yeah.
Avoid breakage. Usually it doesn't break, but we have a 3-piece IOL and it usually doesn't break rather than a single piece IOL.
Yeah.
Now, can I give one more message here?
Yes.
The key to all this, when you have a nucleus drop or an IOL drop and you have a secondary IOL in the form of either an SF or an iris clop, the key is have a good vitrectomy. Rather than doing a limited vitrectomy with a subluxated IOL and then implanting an SF IOL, it always has an insult on the vitreous base and gives rise to subsequent complications. So in all these conditions, before you implant the IOL, the key is to have a good vitrectomy, complete the vitrectomy, including a base excision, and then go for the secondary implant.
And what is that important thing? Like, of course, I think even ensuring that when you're doing this SF IOL or glued IOL, ensuring that you're bringing out the haptics exactly 2 millimeters from the limbus on both sides, so that there's not too much of a pull on the haptic and holding it at the tip, as Dr. Rohit had said. But the other thing is, how do you avoid hypertony in these eyes? Post-operative hypertony, what extra measure would you take?
Intraoperative or post-operative? Intraoperative, we always have our incision in place, infusion in place.
Yeah, post-operative, not to have a post-op hypertony, what would be that final thing you do? I think I'm sure
your flap should be closed properly.
Flap, and also all the
ports should be closed properly.
Yeah. So that's an important message for all of us, that we need to ensure all this is done before we can complete the case and send the patient back. Yes, anything?
I have a question for you, Dr. Thomas. I mean, the sense it was nice to see the old-fashioned, the suture being tied onto the lens itself. I have used those lenses with the eyelets being in the haptics. But I thought in your case, the opening was on the optic of the lens. Am I right?
Yes, sir.
Okay. In that situation, when you are anchoring the optic of the lens or the eyelets in the haptics to the sclera, is it really necessary to bring out the haptics? I mean, they can stay inside, right?
Yeah, they can also stay inside, but it's more comfortable to hold it once you get it out. That's all. You can have it inside and do it.
Okay. No, there's a, for example, when we are doing the old-fashioned SFOL where there were eyelets in the haptics and we are passing the Prolene sutures through that and anchoring it onto the sclera, we used to leave the haptics inside, and it was basically anchored onto the sclera by the sutures. Basically, now with the current crop of SFOLs where we do the brood IOL, create a GABA shaded pocket, etc., we are bringing out the haptics and then tucking it into those pockets or doing a high Yamane technique. But otherwise, if we have those eyelets and anchoring of this thing, then there's really no need to bring the haptics out.
Yes, sir.
Yeah. Thank you very much, both Dr. Kashyap and Dr. Cherian, for bringing out so many aspects for discussion. We shall now go on to our sequence, and I'm very sorry, Dr. Jayanta had not informed you that I was making these changes. And he's none other but a senior consultant, the Retina Center and Eye Care Center from Guwahati, and he has another interesting situation for us to learn. On to you, doctor, and I think his video has to be shared.
Yes, ma'am.
I'll take your leave, ma'am.
I'll be sharing the video.
Yes, Dr. Kashyap. Thank you very much, Dr. Kashyap.
Thank you very much. Thank you.
Just being in your Jharkhand Society meeting. Yes.
Thank you.
Right now, the credit discounts are going on. And for the activation, it takes 48 hours.
Please, I want everybody to mute so that we don't hear unnecessary.
The trailing haptic stuck in the cartridge. What should we do? Once the trailing haptic is stuck inside the cartridge, it should be released without any damage to the haptic for a successful outcome of the surgery. Various methods of techniques are adopted by different surgeons to tackle this situation, but none of them are satisfactory. Those are releasing the trailing haptic by Shinsky hook, push and pull technique, radial cut on the cartridge by MVR knife, implanting the IOL with broken haptic. Sometimes the surgeon compromises the situation by implanting the IOL with a broken haptic. But broken haptic may lead to significant early PCO. Later, the IOL might need to remove due to the decentration. In that case, the surgeon has to either extend the wound by compromising the size of the wound or removing without extension the wound by adapting relatively difficult techniques. Without extension of the wound, the surgeon has to adapt the technique of folding the IOL again inside the eye or dividing it into at least 2 pieces by using a snare for removal. Dr. E. Ahmed in 2012 published a technique for the management of trapped haptic during IOL injection. He demonstrated splitting the cartridge by using MVR blade and releasing the trapped haptic. Later, a lot of surgeons adopted this technique, but I feel this technique was also not very promising. Most of the time, surgeons need an extra instrument to release it manually. By this step, sometimes the haptic may be injured during manipulation. In this video, the author demonstrates a useful technique how to manage the stuck trailing haptic of the IOL which was trapped in the cartridge during implantation. Let us see how I manage the situation with this innovative technique. Considering all factors, the author adopted a new technique to overcome all the issues. The moment the trailing haptic was found stuck in the plunger, which is seen in this video, I hold the plunger in my left hand and using my dominating right hand, I cut a U-shaped fashion block in the silicone plunger with the help of a 15-degree knife, which was used for making side ports. By the moment the AIOS-ARC portion of the silicone plunger is being separated from the rest of the plunger, the trailing haptic gets released automatically without any further manipulation. As prevention is always better, we need to understand why does the haptic get stuck in the cartridge. The answer to this could be poor quality of the cartridge or inserted system, the faulty technique of the IOL loading, insufficient use of viscoelastic substance. This situation can be avoided by using proper technique of IOL loading, like thorough irrigation of the cartridge by BSS or ringer lactic solution before using viscoelastic, use of sufficient viscoelastics, proper loading of the IOL in the cartridge. Thank you.
Thank you very much, Doctor. That was a wonderful way of very simple thing you picked up and you discussed it piecemeal, and just very nice. I'm sure all of us relearned something as we keep watching the small issues which come up in all these videos. Thank you very much. Now, of course, just when it comes to talking about injector, both Ramurthy and Rohit.
Yes, ma'am.
Yes, I just have a question. Now, what are this? Dr. Gaurav has joined. I had this question for Gaurav in mind, because Gaurav does a lot of hydroimplantation. Now, when you are, have you ever thought the challenge which you face when you are using a screw type of injector, and what is the challenge which you face? Oh, he's not got connected. Anyway, you all can answer. Screw type of injector or a push type of injector, what are the challenges which you face if you want to do a hydroimplantation? Gaurav?
I just joined. The question is on hydroimplantation, ma'am.
No, the question is, this was a stuck haptic that got released and he showed a nice way. I just thought because his thing was so completely explanatory, I thought I'll just move and talk about the injectors. Since you do hydroimplantation, would you use a screw type or would you use a push type?
Ma'am, for hydroimplantation, you have to use a pusher only. You cannot use the screw type at all, because one hand is for switching on the infusion, and the second hand has to be used. So you can single-handed injectors are only possible. And that's why there is a problem with, and also if your IOL gets stuck, you said that one haptic got delivered and the other one did not. This is one of the problems with hydroimplantation, that if that happens, sometimes you are in a little bit of a soup and you have to know how to deal with it. Otherwise, they can.
How would you deal with it?
Ma'am, the main thing is that the main incision should not be kind of open to leak. So you have to quickly ensure that the main incision, even if it's a haptic, it's fine, because then the incision is not leaky. But if there's part of the IOL inside the incision and it's got stuck, then there will be a problem. So you keep the infusion on, and then from a second side port, you put in viscoelastic as a rescue thing. Otherwise, you can't deal with the situation very effectively or very safely. So this is a situation. Yeah.
This was what I wanted to be brought forth when I was talking about screw type and push type. But when you talk of push type, I also want to let us all understand that there's a lot of fashion about doing a wound-assisted implantation. I think with the push type, you cannot do a wound-assisted because it can get released suddenly and go and hit the opposite end. Don't you think so?
No.
So?
In fact, I always do wound-assisted, and I use a shooter for all my IOL injections. So it works very well. Only thing is, yes, with certain IOLs, you have to be more careful, because it can kind of go into a sudden injection. But that can happen even with viscoelastic. But shooters, definitely it is possible. And more so, I've seen with Alcon lenses. So I put Alcon lenses actually with the J&J injectors now, because there the risk of that sudden injection is less.
Okay. Dr. Rohit, Dr. Ramurthy, anything to take on in his presentation, which you want to ask?
What Dr. Jen very nicely showed, one thing is prevention is better than cure, as he mentioned. So whenever you feel resistance while injecting the lens, do not go ahead and push the lens inside. I mean, whatever be the type, it's usually the overriding of the plunger onto the optic or the haptic which causes the problem. So if you have facing a resistance, don't go ahead and push it, because then in that case, it's always a good idea to bring out the lens outside and re-roll the lens and go ahead. And as regards wound assisted implantation. I've been doing this very regularly for the past 6 to 8 months. And I think it works well. And as Gaurav said, you always have to use a push type of injector because you need the second hand to be free to hold the irrigation cannula. And what I do is to introduce the irrigation cannula a little more inside, almost halfway into the anterior chamber. And the lens goes under that. And that gives me a little more control in the way it unfolds and the way the lens is guided into the anterior chamber. And I also increase my bottle height, or in my case, the intraocular pressure, to almost 70, 80 centimeters, so that I have a very well, nicely formed chamber just at that point of time, and the posterior capsule is well behind. Having said that, in case you are expecting a more difficult implantation, the intraocular lens, it's a very thick lens or something, then a push type is always, then a screw type is always better, because it leads to a more controlled release of the intraocular lens rather than a push type, which at times can lead to explosive release of the intraocular lens in the anterior chamber.
Very good calls, sir.
Yeah.
I was in fact going to mention that, when you're using, a kind of like a screw type of injector, it becomes very nice because you can actually, but you can't do wound assisted with a screw type because, you don't have counter pressure. Whereas with hydroimplantation, you have counter pressure with your left hand. So you can actually do wound assisted much better with that. And as sir said that, you can actually introduce the nozzle straight to the mouth of the rhexis and deliver your lens there when in tight situations, rather than trying for, using a shooter with wound assisted where it'll be more unpredictable opening kind of a thing.
Yeah, and Dr. Sugato Paul has a point here that if you use an AC maintainer, you could even do hydroimplantation with a screw type, as he says. I am not a great fan of hydroimplantation. I don't think removing visco is a big challenge. Dr. Rohit, anything to add before we go on to our next speaker?
Yeah, I've had mishaps twice while using the shooter. So ever since that, I've stopped using it. I only use the screw type. And if I have to use it, the shooter type, it has to be a disposable one, the way Hoya people have it. So I'm a bit, but I would love to, get into the hydroimplantation because that relieves so many things. But since I'm using, a calibrated side port incision, so for that you cannot have, you will have to enlarge it. So my preferred technique is that I use the screw type one because that gives me more control.
I had exactly the same thoughts, Rohit, but I saw in a live surgery, and hardly it's about 7-8 months since I started using microimplantation, and I really like it. I mean, you have to be a little more careful, and especially nowadays our implantation of toric intraocular lenses has come much higher, and you save so much time. There is no viscoelastic to be removed. Just with the hydro, you can position, especially when you have a digital overlay system, you can exactly position the toric intraocular lens. And the surgery gets over as soon as you introduce the lens. For a master surgeon like you, I think, it's just a few cases. Of course, you have to be careful of some mishaps happening, but then it seems to work well.
Even post-op IOP spikes are not seen much with hydroimplant.
Yeah, I'm sure it is a technique which has to be learned and done properly. So we shall now go on to our next speaker, Dr. Sajjad, and he has again something different to show us. And Dr. Sajjad is again a professor from SKMS Medical College, Bhimina, Srinagar. And we look forward to watching your video, Doctor.
Good afternoon. Thanks for getting me as a speaker. Basically, I am sharing a case which was as phacomorphic hypermature cataract with very shallow AC. So I initially thought I'll just go ahead with the this envelope technique without disturbing much things, and maybe I have to extend incision for the going simply through SICS, not the phaco. But to the luck, the edges got inverted on either side of these envelope part of. So after that, then I decided just to release the margins with the this 1R scissors, and then complete the rhexis with the microforceps. So this was how I found that the rhexis is not running away, and I may be comfortable to complete the rhexis. rightly without extending, and maybe I'll go ahead with normal phaco. So the rexes I completed later with the help of the capsulotomy needle, and I couldn't just get it through it. So after this, I decided now to go with the phaco. So the rexes is quite good to maintain the emulsification procedure. So that is how I did the direct chop, completed packing and taking all the bits of the nucleus very comfortably. Without any hassles. These are some of the last pieces. Then putting normally and closure of the ports. So that was a very comfortable end of it. Thank you very much.
Thank you very much, Doctor. The questions are, now in a phacomorphic glaucoma, I'm sure we would all ensure that we give mannitol or oral glycerol to soften the eye. But in a phacomorphic glaucoma with an intumescent cataract, would any of us consider even being prepared for a limited vitrectomy along with it? Or do we go for a small central opening and decompressing the bag and go about it in a standard way after with the pre-op measures alone? Gaurav? Gaurav, unmute yourself.
Am I audible?
Yeah.
Yeah. So I'm not a fan of blind vitrectomy. I mean, if I can't see, I've seen it being done by some like big people, Dr. David Chang and few others, but somehow I don't think it's a great thing. So I would be more in tune of like, giving measures like giving mannitol and Dimox to the patient beforehand, and then preparing well for the surgery with all the measures like, using good viscoelastic, soft shell technique, hydro, kind of decompressing the lens with a side port. I mean, going through a paracentesis, all those things which have been described, starting with a small rexis and enlarging it, all those things that can be done. I would be definitely do all that. And I would maybe not, do a primary vitrectomy just to, I would also look at the lens thickness, I mean, if possible. And also I would look at the AC depth. They are big predictors of also the, how the anterior curvature of the lens is. And so even sometimes doing an OCT of the anterior capsular area, it shows you pockets which can be seen. Dr. Dhami's team, their group has described that, and you can see on the slit lamp also. So, but phacomorphic definitely requires special attention. Yes.
Yes, Dr. Rohit?
I think Dr. Gaurav has mostly all the things.
Yes.
So I would do a closed chamber cortical decompression.
Yes.
And then create a small rexis, do the cortical debulking from the periphery, because when you're trying to enlarge the rexis, because in the mid periphery, the cortex has not been taken care of when you're doing cortical decompression. So that should also be taken care of. Vitrectomy, definitely, I would definitely not go and venture into that by any means. Mannitol and everything, as Dr. Gaurav has perfectly said.
And also remember that the rexis needs to be enlarged at the end of the procedure. But when it comes to doing a decompression, would you use your syringe, or would you use your IA, or would you even go ahead and use your phaco probe?
No, Doctor.
No, I'm just putting all the things on.
Yeah, Dr. Mohan is a great fan of doing that punch, that phaco punch. It has not caught my fancy.
Yeah.
So I used to the syringe with a 30 gauge needle.
Yes.
I use a 30 gauge needle.
Yes.
Yeah.
Yes.
And we should have a syringe which is 2 ml or 1 ml, not a 5 ml syringe, because it will set up a very strong aspiration and also go from a fresh paracentesis port with good viscoelastic, filling the chamber so that, and we should not forget femto assisted rexis if the option is available. That's a big saver as well.
And what would be the viscoelastic which you would use? Would you want to use only cohesive, or would you want to do both cohesive and dispersive, or would you feel that dispersive will do?
Usually one should use a visco-cohesive because you want to, flatten the anterior capsule. But if you're using it, if you're doing with a closed chamber and with the fresh paracentesis, because at times with the majority of the audience, they would not be handy with the, a visco-cohesive for that matter. A visco-dispersive with a guided, as Dr. Gaurav has said, don't use a 5 ml. I use a 1 ml, 1 cc syringe to just aspirate.
Okay.
I would like to give a slightly different view on this anterior vitrectomy. I think it's really a lifesaver in certain extreme situations. Obviously, all the preoperative measures that was mentioned by both of them regarding use of IV mannitol, even giving a periocular injection and then giving nice massage, all those things can be tried. But sometimes in spite of all these measures, the intraocular pressure doesn't come down, or as soon as you make your first incision, there's a lot of upthrust. In these cases, even though obviously in extremely small eyes, it might be difficult to even identify where the pars plica ends and where the pars plana starts. But in normal eyes, you can go at 3 to 3.5 millimeters. I have done it on a few occasions. Just putting in a trocar itself with the surge of fluid that comes out, or just going in with a vitrectomy when just removing about 0.1 cc to 0.2 cc. I don't even introduce a irrigation cannula inside. Does immediately you find that things come under control. The lens iris diaphragm goes back and things are more under control. It's not that I've done this frequently, but there have been a few occasions when I had to do it either preoperatively or intraoperatively when I find that the upthrust is quite unmanageable. Intraoperatively, I am a little more wary of doing that because if it's a suprachoroidal hemorrhage that's causing it, this could end up in a fairly difficult situation. But preoperatively, doing it as a first step, and even before you opening up the anterior chamber, making an incision of 3 to 3.5 millimeters, going with a vitrectomy cutter and just doing a very limited anterior vitrectomy sometimes does make things come under better control.
I would, I think I wouldn't be too sure. Like Gaurav, I still believe it's a blind procedure and there is a challenge, and the anatomy of the eyes, of course, you said in normal eyes, you could consider an anatomy of a small eye is a very big challenge, but I think we need a retina person amongst us to really put it right with full clarity. So yes, we should be conscious about the challenges of doing it. So I wouldn't want the audience to go back with a message. Maybe they could, initial cases, they could have a retina colleague doing it for them if they are caught in a situation when they feel the entire surgery is going to become very challenging. We shall now go on to our next speaker, Dr. Gopal Arora. And again, Dr. Gopal Arora is a very popular person from Nagpur, in fact, MOSCON, and he's been the president of MOSCON and has done a great job during his tenure. And he's the director of Akshar Eye Institute, Nagpur, and he has an interesting learning surgical video for us to see. On to you, Dr. Gopal.
Thank you, Dr. Chitra. Thank you, Dr. Chitra, and the entire team of ARC. Am I audible?
Yes, yes.
This cataract, an intumescent cataract, is, you find this every second OT. And it goes without saying that you need to stain it with Trifon blue before you start doing rexis in this case. And once you have done your main incision with a keratome, you just again need to flatten the capsule so that the pressure is behind, and start by making a small nick in the anterior capsule. You can go with a needle or a rexis forceps, whatever is your choice. Once the nick is done, you again need to refill the anterior chamber time and again so that the pressure on the capsule is more and the chances of extension is less. And exactly that's what I've done here, and I'm taking a bite. Now you see, I should have taken my forceps out, which I did not do, and I should have taken a smaller bite. I was greedy enough to make a bigger bite, and then the rexus goes away. But now, since it's done, what next you can do? You can just make with the Vanna scissor extension on the nick on the capsule, which is extended, and just pull out that anterior capsule with again a rexus forceps. But as you see, the rexus which has extended on the one side, there is a asymmetrical rexus margin. So you just need to debulk, as I mentioned by the previous speakers, you just need to debulk and reduce the intralentricular pressure by removing the loosened cortex or the epinucleus. Since it is slightly an eccentric rexus, I would just make a nick on the other side to make it as symmetrical as possible by a smaller nick, and then pulling off that anterior capsule again by using a rexus forceps. This is from one end, and similarly you do it from the other end, and it becomes not exactly, but somewhat little symmetrical on both sides. Again, since it's an intumescent cataract, we are not very sure whether it's a posterior pole or the stuff. Again, you need to be very gentle. The insertion of the phaco probe in the tip, and then you need to do in a technique which I normally follow is the direct chop, but make sure that the phaco probe or the tip do all the manipulation and eating mostly in the center of the nucleus. So at times you have even to take the nuclear pieces slightly into the anterior chamber, as you can see, so that there's less pressure on the side where the rexus has extended. Once the entire nuclear piece is out, then you need to remove the cortex of the epinucleus. Here there is one trick, because the rexus is extended on one side. I would not like to use the IA. Instead, I would put a viscoelastic and remove the cortex, sort of a visco expression by one cannula, because I've done only a one side port from the left side only. So you just put in a visco, take out the cortex, and subsequently, maybe it might take time, but you remove the entire cortex. And then implanting, this is again a trick. You should just, with the irrigating cannula, just keep an irrigating cannula over the IOL so that the leading haptic actually goes inside the whatsoever bag is left with there, and then it goes behind the rexus margin. Again, an important step here that you should not be completely dialing, because that in the leading haptic might actually find its way onto the extended rexus margin. So the loops can be held by a Sinskey hook, and gently the same loop can be put inside the bag, and without having stretching on the area where the rexus has extended. So once the IOL is in place, it's inside the bag, you can just remove the viscoelastic and hydrate the two side ports and the main incision. So just a few tips that you need not worry, or you should not be taking too long a bite, and the probe, tip of the probe should actually deal with the entire nucleus only in the center of the cataract. Thank you.
Thank you very much, Dr. Arora. That was a wonderful surgery and multiple tips and very simple messages which kept coming through. Dr. Ramurthy, are you there? Yeah. Now, as far as the phaco is concerned, the actual surgery, what would be the extra message which you want to give, anything besides what Dr. Arora has already told, the phaco part of it?
I think once he had the complication, he handled it very well. My only maybe by doing it happens all the time in my hands also, is rexus and intumescent cataract. Is not that we have a sure shot way of preventing it in 100% of the cases. But what I know, this is a situation where definitely a cohesive viscoelastic will help. And though he introduced a viscoelastic and again refilled it, one thing I noticed was that he never debulked the lens material from the bag. So in these cases, when it's a flocculant lens material and it's a convex lens surface, apart from introducing a cohesive viscoelastic, I would also, after the initial nick, whatever way you want to do it, I would go ahead and with a, sometimes nowadays I go in straight away with a 26 or a 30 gauge needle into the center of the nucleus and first evacuate lens material through the side port, and then that sort of debulks the intralenticular pressure, and with a cohesive viscoelastic you have a little more control. And then as far as doing the rexus itself is concerned, you going through the side port either with a micro-rhexis forceps or with a 26 gauge bent needle gives you a little more control, because in these cases, when you go through the main incision, even a little bit of escape of the viscoelastic immediately shallows the anterior chamber, and there is a tendency for the nucleus to run away to the periphery. And one thing, I mean, as far as the phaco part is concerned, I think handled this beautifully. But these are situations, because most often these are associated with a very soft cataract. I would not hesitate to prolapse the entire nucleus or even the bits of the nucleus into the anterior chamber and do most of the phacoemulsification in the anterior chamber. It's most often just phaco aspiration. You can use a nice dispersive viscoelastic coat so that you don't stress the capsular back to the extent possible. And one very nice thing I noticed about this video was the way he did a hydroimplantation. And that's the point I was trying to make earlier also, where I introduced my irrigation cannula almost midway into the anterior chamber. And that itself gives me a control over the introduction of the intraocular lens, and the lens actually goes under the irrigation cannula. I think that's a nice tip that was demonstrated.
Gaurav, I mean, we all know that Rohit, the motility sign which he has told us is something which keeps coming to our mind and all those theaters when we have that kind of a challenge. But there is a time when you would even consider, would I do a phaco or should it be converted to an SICS? Is there such a moment at all?
Yes. So in fact, there can be that thought, most of us who are proficient phaco surgeons, first of all, it depends on how proficient you are with phaco.
Yes.
And if you have a situation like this, and if you're very proficient, you should many times be able to get away with it,
Yeah.
And however, for a beginner surgeon, first of all, they should definitely consider those who are probably taking more than 10-15 minutes to do a standard phaco are probably those who are not so, comfortable with the maneuvers of cracking the nucleus and everything. They might as well consider switching to, an ECC or an SICS kind of a situation. Also, I think if it is a black cataract kind of a thing, or if there are other situations where the capsular bag is not very healthy, or there is pseudo exfoliation, potential zonular weakness, and maybe a pupil which is getting smaller. So if you are faced with other comorbidities and challenges, definitely worthwhile shifting, because then you'll just keep adding to the problems. So these are the situations where, or if you have a bad cornea, and a lot of other possible things which can complicate a surgery. So these situations, I would think that one should be able to convert.
Very rightly said. And Dr. Rohit, is there, now this was a single piece which was placed and very nicely placed without any rotation or any movement in the capsular bag. Would you think that this is an ideal case for putting a single piece, or would anybody consider a 3-piece IOL?
The most important thing is that the flap was fluttering right at the end. So this means bag, it had not extended posteriorly.
Yeah.
So, you would like to, the more important thing in this is how you place the intraocular lens with an extended flap. It should not be in line, because that we have to create a situation wherein there should be less amount of decentration in the post-operative period. So keeping that in mind, the IOL has to be positioned in such a way. So if you can put a 3-piece, nothing like it, even a single piece would definitely have gone in without any issue, as he did perfectly by just flexing the loops rather than putting more stress to the capsule or to the flap, which could have become a wraparound tear.
Yeah, yes, very rightly said. Wonderful video, Dr. Gopal. So we shall now go on to our next talk. Dr. Ratish Paul is here. He's not here. Oh, okay. He had a very nice video to show. So we shall now go on to Dr. Jason. Yes,
Madam.
Yes, Dr. Jason. Jason is another very amazing surgeon from Kerala, and whenever I've gone to the Kerala State Conference, I have been always truly impressed with the very casual way with which he'll come out with a string of his videos. And he's the senior consultant, Jyoti Eye Care Hospital, Palli Kannur. So on to you, Dr. Jason, and let's learn something more from you.
Good afternoon, madam. Am I audible?
Yes.
I'll share my screen. Is it visible?
Yes.
Today I'll be showing a few cases of DM detachment managed by desmetopexy with iso-expansile C3F8. So in this case, this is a hard cataract, these are the predisposing factors: age, fuchs dystrophy, pseudoexfoliation, prolonged surgical time, and blunt instrument. These are the predisposing factors for DM detachment. I don't know which has created DM detachment in this case. Probably I have injected viscoelastic between stroma and Descemet's membrane. And I had a tough time to wash off this viscoelastic in this space. So without creating further extension of the Descemet's membrane detachment. So, so that visco is cleared, and I have used 14% iso-expansile C3F8. You are supposed to fill 2/3 of anterior chamber using this, and the site of entry is through the clear cornea, where DM is attached. And at the end of procedure, I'm supposed to place sutures. This is to prevent C3F8 loss, which can happen because of the secondary glaucoma, pupillary block glaucoma. This is the third post-op day picture, and this is the first week post-op picture, and this is the third week picture. You can see clear cornea using this technique. The second case is a spontaneous Descemet's membrane detachment. This happened after 3 weeks following an uncomplicated cataract surgery, and her vision dropped from 6/9 to hand movement. And this patient had a bilateral cornea guttata, and surgery was uneventful. I have used heavy molecular weight viscoelastic also. And there was no chance of a surgical error in this case. And postoperatively for 2 weeks, it was normal. And third week, she developed this. So this case also, I could attach good result I could get with the C3F8, iso-expansile C3F8. But unfortunately, third week patient came up with this picture. And again, it was taken up for reattachment. Using C3F8. Again, the same wound paracentesis was opened. I can see it is made in the clear cornea where there is no detachment, and C3F8 tamponade is done. And this time, the technique is supplemented with internal fluid aspiration. The fluid between the stroma and the Descemet's membrane is aspirated using making a small incision. Not exactly at the center, just below the center of the cornea, and the fluid is leaked through the wound. And this was the initial result was good. This was the second week picture, and you can see only a small area is detached now. But unfortunately, again, patient had a detachment. And this time I was forced to supplement with transcorneal sutures, including the Descemet's membrane. This OCT is after suture removal. You can see the suture track here. This is the 1 month post-op picture. Now you can see the corneal scar because of the corneal suturing. This is third case. This patient presented to us 4 months after cataract surgery. And because the surgery was done elsewhere and DM detachment was not attended. And this case also we tried injecting C3F8 and a transcorneal through and through suture, including the Descemet's membrane, was done. So this is how it is sutured. And I would like to share, this patient underwent other surgery following when he came first instance itself. And that I also had Descemet's membrane detachment, but that I could manage with C3F8. But this eye was a failure, and patient is waiting for a DMEC procedure. The conclusion is descemetopexy is a useful technique. Sometimes you may have to combine it with sutures and internal fluid drainage. Thank you very much.
Thank you very much, Dr. Jason, for the wonderful array of videos which you showed, which brought home your point. But I have a very basic question here, and I want my expert panel also to give their opinion. My thought is that an air is sufficient in majority of the situations, unless it's a very bad tear and you feel you need something, a longer non-expansive gas to be staying there and not an air bubble which might not stay that long. I would rather do with the whole thing in majority of the situations with an air bubble itself, and not think of using a C3 effect gas. Keep it only for very bad DM detachments which need a longer time. The second thing is, how easily would you think of doing a venting? Because you could even have epithelial ingrowth and seeding and all that. So, but then if there is a viscoelastic in that interface, maybe then you would have to do it. But would venting be easily or commonly done at all? And of course, did that transcorneal suture actually keep the DM in place? Because by then, a few months, the DM area of DM detachment could get fibrous too. So does the opposition occur well in those situations? I have these questions to you, Dr. Jason.
Madam, initial days I was using air only. I was not used to this C3F8. And very recently only I started using C3F8. I think results with C3F8 is much better compared to air. Air initially what I used to do was I will overfill the anterior chamber.
Yes.
And in 4 hours time I will again evaluate that patient. Probably that time patient would have developed papillary block glaucoma, and a control leakage of the air is done. Usually when the DM stays for 3-4 hours,
yes,
usually they stick on.
Yes,
they stick on. But with the C3F8, you don't have to overfill. And that is the advantage I found. You just have to fill the chamber 3/4, 2/3, I mean, and you ask the patient to lie down flat 3-4 hours every day. And this is doing wonders actually. You don't have to face the...
You do inferior PI in all your patients?
Actually, I recommend doing inferior PI. I've never done, but every time when you develop secondary glaucoma in these cases, I thought of doing a PI. So I recommend PI, inferior PI, when you get DM, when you are managing DM detachment, because you don't have to face the issue of secondary glaucoma. That will really manage, block the development of secondary glaucoma.
Yes, Dr. Gaurav or Dr. Rohit, anything to add here?
Yeah. Since the time we got the AIOS-ARC, so that has really helped in visualizing everything. So that is something which can be a big boon in such situations. Dr. Gaurav has also ordered, if I'm not wrong. So he's also going to have an AIOS-ARC with that RT-VOID. So I have also, the question which you asked, the second part of the question was, in those, I have always used air for that matter. And I have not still ventured into using what Dr. Jason is using. Yeah, absolutely. And all that I do is that I make the patient, you have to be very clear from where you have to go in.
Yes.
And then you have to inject air. You have to give patient Diamox post-operatively, make the patient lie supine. And you know, that mostly it does the work. But if required, you can repeat it after a few days. But in all my cases wherein I had the need to do it, I used only air in all my patients.
Yeah, and you should suture your wounds also.
Absolutely. And there should not be, the air should be, you know, should remain there. There should not be any leakage.
Yes.
Because that is going to create a situation wherein the membrane will again, you know, find its way to get detached. So that is the most important thing.
As Dr. Jason has said, the 3-4 hours wait is quite enough for the DM to get attached. Yes.
Ma'am, I wanted to add a couple of things.
Yeah.
So Basically, if it happens in the primary surgery, and if you have a small superior DMD, it's pretty easy to just, let it settle and put air, and it'll take care of it. But if you're dealing with a DMD which happens later, for example, it's been there for a couple of days, or in one of his cases where it happened subsequently, the chances are that, the air will not be sufficient to let it settle back, and you will get a recurrent DMD within a day or two. It might remain there for a day or two, and then it'll just happen again. So their C3F8 definitely becomes much more useful if it's a, like a older DMD, or if it's happening a second time and you need to intervene a second time. So C3F8 is very, very useful. And also if it's an inferior DMD, then they are much, much more challenging to deal with, because they tend to not settle down. And even if they settle on table, they will happen again. And rarely, we've actually had to do C3F8 2-3 times, and then also do the venting incisions and the suturing to manage this. And then these measures are required at times to deal with recurrent or inferior DMDs. I think, and sometimes if it starts from the side port, especially from the main port, most often it'll be usually a limited one, which is because of your instrumentation. Sometimes from the side port, if you're pushing fluid or viscoelastic, it creates a fluid wave and creates a big DMD. And there you have to be very careful, because if it's viscoelastic, whatever you might do, it will not settle down and it will just keep recurring. So to ensure that viscoelastic is removed from between the descemeents and the stroma, you have to make sure that it's washed out adequately as well.
And important thing is, sometimes the patient may have corneal edema and you may not have expected a DM detachment. So you could do just hypersol, or you could use glycerol on the epithelium, and so that you get clarity, or even use an endo-illuminator if you, or a transconjunctival illuminator, and locate the DMD, and then locate how you're going to go about what is the extent, and then plan how you're going to inject your air bubble from which side port. And as Gaurav had said, that the side port hydration can also be the final mission maker of creating a DM. So you need to ensure that your side port is hugging the stroma as you are hydrating, and not entering the incision at that point of time. It is also very important that the eye is not too soft, hypotonic, or it's a shallow anterior chamber. Never use blunt cannula, blunt instruments, or even a loose sleeve of your phaco probe could actually tent up the DMs. So these are all some essential tips. And again, you take our port inside, phaco probe inside, and then start the infusion, because there might have been a small inadvertent DMD you've created. And if the infusion starts even before you have entered the AC, that could further unfurl the DM. So we need to be careful at every step of the surgery in the initial parts to avoid it. And if you have had it, then you could do a retroillumination and see it to locate the DM, and you could still do it. And of course, if you have the OCT, then it makes things a lot easier. So I think, yes.
Quick points, I mean, in the sense that I agree with Jason and Gaurav for most of the things they said. Yeah. And we also, whenever we are faced with this situation, air suffices. But when it's a recurrent DMD, yes, then using a C3F8 mix is a good idea. And just for the information of others, the way it's done is you take 0.2 cc of C3F8, and it's a 1:5 dilution that you do. Take 0.8 cc of air. And this is an ISO expansate. So if you don't do an overfill, the chances of it creating a very high intraocular pressure is somewhat limited. And at the same time, because the gas remains in the chamber for a longer time, it works quite in a better way than just filling it with air. One other factor that you need to keep in mind is when the surgery has gone off totally uneventfully, and the first postoperative day you find significant corneal edema, you are sometimes forced to differentiate it from a TAS situation, where you can have absolutely white sclera, everything eye being quiet, but the significant corneal edema unfolds. If it's limited to a certain area, then in those cases it might be more of a DMD. But if it's a limbus to limbus, and then it becomes a little more difficult to differentiate. In these situations, maybe doing an anterior segment OCT will help, where the detachment of the DMD will become more obvious, and it can be managed in the base it has been shown. Of course, I feel that the venting incision may not be necessary in most cases, simply because the moment you do a good air fill or a C3F8 gas fill, that itself massages out the fluid between the descemeents membrane and the rest of the stroma. And I'm quite intrigued by what Dr. Jason said about 3 weeks later, a spontaneous detachment. I never faced this situation. I mean, is it been described?
Yes, it has been described as a late detachment which can occur. It was because initially the edges get fibrous. So, it stays, apparently stays okay. But anyway, some of these eyes are basically eyes with an endothelial disease.
What
where
he says is that the cornea was looking good for 3 weeks and subsequently it developed the DMD. I mean, can you answer that, Dr. Jason?
Sir, actually, that patient had Fuchs dystrophy, both eyes. And it was an uneventful surgery because Fuchs was identified before surgery. Actually, we have used heavy viscoelastics, and we didn't expect any issue. And patient had 6/9 vision for 2 weeks, and then suddenly developed a DM detachment. This is not my first case. I had another case which I couldn't record. That patient also had this kind of issue. That patient endothelium was quite okay actually. Patient developed DM detachment after 2 weeks. And second day when I operated, I took all measures. It was a very easy cataract, all measures. And I could do without DM getting detached. But that surgery was done during the within weeks after the first surgery. So I was managing the DM detachment in the first surgery. Since patient's vision was very poor, I was forced to operate the other eye. So I gave Diamox for the first eye for the secondary glaucoma. And because of when I started Diamox, second I developed some corneal folds. And I started feeling that it might get detached. And there was a small OCT. I could see the subclinical detachment in the second eye. But the moment I stopped Diamox, it got reattached. So I think there is, and the same patient developed recurrent corneal edema in the next year, and which was treated with micropuncture. So I think some patients has some basement membrane issue, which is creating this spontaneous detachment.
Thank you. Thank you, Dr. Jason. So we shall now go on to our next presenter, Dr. Amita Verghese, who's a medical director from Microsurgery and Laser Center at Kerala, and is again a specialist in phacoemulsification, glaucoma, and pediatric ophthalmology. And we look forward to watching her video and learning some more. On to you, Dr. Amita. You have to unmute yourself. Unmute yourself.
A very good evening.
Yes.
Yes. Yeah.
Can I get the presentation, ma'am?
Yes. A very good evening to one and all. I'm presenting a case of a cataract on the second eye of a 51-year-old male patient with a posterior polar cataract. The first eye had an uneventful smooth surgery with implantation of a multifocal plate haptic IOL. The surgery was done under topical anesthesia after making a capsulorhexis of about 6 millimeters in size. As the events unfolded, trying for a hydrodelineation, it became a hydrodissection. Without rotation of the nucleus, a trench was created and phacoaspiration was done under low parameters in the epinucleus mode. During the process, the nucleus prolapsed and flipped, and I could see the plaque of the PPC on the back of the nucleus. I could phacoaspirate 3/4 of the nucleus when I noticed a clear area in the posterior capsule, and there was resistance of the nuclear material to aspiration. I stopped at that point. I tried to inject OVD from the side port, but I could not do it. So I removed the phaco probe and injected OVD to keep the nuclear material from going into the vitreous. I could see a linear tear perpendicular to the main port. With the help of a vitrector, the nuclear material was cut and aspirated along with the anterior vitrectomy, and then cortex was aspirated in the IA cut mode. The retro-illumination of the microscope helped in visualizing the rent clearly. As the rent was perpendicular to the port, I proceeded with the original plan to implant the planned multifocal plate haptic IOL.
The screen has become, has it the same? Yeah.
So now we can see the rent quite clearly. And I finished the cortical aspiration. And this is the intraocular lens implantation being done. And I try to center the IOL. The leading one of the leading haptic was still outside, and I tuck it into the bag. And then I check for the centration of the IOL at the end of the surgery. The 4-point fixation has helped in well centration of the IOL. Post-operatively, the patient has an unaided visual acuity of 6/6 N6, but he did complain of some floaters. And this was because some of the nuclear material had fallen into the vitreous and it had dispersed. I think both the patient and the surgeon were lucky to come out of the difficult and tricky situation. I thank Dr. Chitra Ramamurthy and her team for giving me this opportunity. Thank you.
Thank you. Thank you, Dr.
This is a
Amita.
post-op picture.
Yeah. No, the video has gone. Thank you very much, Dr. Amita. There were some important points which could be discussed. Dr. Rohit, could you enlarge for the younger audience about cut IA and IA cut and what parameters you should have when you're doing this?
I think it was a beautiful presentation by
Can you unmute yourself, Dr. Das? Background noise. Yes.
Yeah.
शिशिपुर ज्यादा दूर नहीं है क्या है शिशिपुर में
You have to unmute yourself. Yes. Dr. Jayanta Das, you have to mute yourself.
Yeah. I think the most important factor which we all should know, you're talking about cut IA and IA cut.
Yes, yes.
When you're doing vitrectomy, the most important thing is, first of all, you should visualize whether the vitreous is there or not. If by any means the vitreous is there, then you have to go into the cut IA mode, wherein you have to do the cutting with the maximum cut speed and cut the vitreous. And once you are sure that you have been able to get through with it, then you can go it into the IA cut mode. I'm not sure whether all machines do have that or not, but the machines which have that, this should be used to our advantage.
Yes.
That is the first thing which I would say that if we have to see, the way she managed it, I think it was outstanding how she did it. Yeah, but then, if a few things which I would like for the audience, in all patients with the posterior polar cataract, you need not go in for such a large rhexis as a 6 mm rhexis, as she said. Low IOP phaco is a very important part in this, because even if the capsule is open, if the IOP which you are using is around 24 or 26, that will not hydrate the vitreous. That will not that will not enlarge the capsular tear to the periphery. Number two, and that will not push the nuclear fragments behind. So a low IOP phaco is a very important factor in those patients where you have an open posterior capsule. Another important thing which I would like the young audience to take home is, if you cannot make the rhexis circular, the posterior rhexis circular, try not to venture into putting an IOL in the bag, because while implanting the IOL, you can create a situation wherein there can be radialization and there can be a delayed, of the IOL going into the posterior segment. So if you can do a radialization, or if you can, circularize the posterior capsular tear, that is absolutely what we should aim for. And if you need to have the experience of Dr. Amita to go in and put an IOL in the bag in such a situation.
Yeah.
So that is these are the take-home points. And oval rhexis, which has been advocated, is also something which can be tried, because that gives the advantage of both a large rhexis and a small rhexis. So,
Yeah.
and if by any means, if you have to use a trifocal lens, I think you can use a multi-piece also, a trifocal lens in the secondary stage if it is not available at that point of time.
Dr. Ramurthy, I want your thoughts. If it was a toric IOL and you have a single piece, what are your thoughts of doing a reverse optic capture in these eyes?
Well, I think very nicely managed, Dr. Amita. Difficult case and nicely managed.
Yeah.
Yes, the advantage of a pure multifocal is that you can implant the lens wherever the capsular support is there. Like in this case, she had it in the 6 o'clock, 12 o'clock meridian, so she could, she was seated temporarily and she could implant the lens in that. Rather, she had it support in 3 o'clock, 9 o'clock, and she could implant the lens in that meridian. In toric intraocular lens, you do not have that advantage, and it has to be positioned in a particular manner. So in these situations, now that all of us are taking up these multifocals and torics more often, and they are not available in the three-piece platform, the conventional wisdom was that you never place these intraocular lenses in the sulcus. It's always in the back. If it's in the sulcus, then it has to be a three-piece. Nowadays, occasionally we have to resort to these gymnastics. There have been a few situations where, a couple of situations where they had a PCR in a case of a posterior polar cataract and a toric intraocular lens had to be implanted. I've done both a conventional optic capture and a reverse optic capture. In both these cases, basically the lens had to be oriented in the 0-180 degrees axis. And when there was support in the temporally and nasally, I actually implanted the lens in the back and created a reverse optic capture so that the lens was fixated. While when the support was lacking inferiorly and there was a tendency for the haptic to sink inside, I brought the haptics outside and created an optic capture. That's a conventional optic capture where the optics of the lens is held by the rhexis margin. So as Dr. Rohit said, creating a 4 to 4.5 millimeter rhexis in these situations is a good idea. It's always a good idea to use an AIOS-OCT in these cases, evaluate the risk, and of course, pre-warn the patient that the multifocal or the toric might have to be given up. And as regards Rohit comment regarding converting the rhexis, that the posterior capsular tear into a circular rhexis, it is applicable to most instances, but sometimes it's not relevant to a posterior polar cataract, because like you saw in this case, it's actually what you get to a pole-to-pole tear. It's a splitting up of the PC that occurs in these posterior polar cataract, and there's really no way that it's going to extend. If it's just going to be a rent with a circular margin, indifferent margin, definitely the gymnastics of introducing viscoelastic lens will extend the rhexis. But in these cases, we are able to do a good anterior vitrectomy and then position your lens accordingly. Sometimes create making a circular excision is not necessary, or it's quite difficult also.
Dr. Gaurav, everything has been said. Anything to add, or shall we go on to our next?
I would only say that a word of caution that plate haptic lenses have a very funny way of, dislocating through a broken posterior capsule. Sometimes even from a small laser capsulotomy, they kind of expand it and they will find their way into the vitreous cavity. So I would be very, very reluctant to put a plate haptic lens with a broken PC of the kind that was there. But ma'am, you managed it so well. So it looked very elegant, but we don't know about what's going to happen later. Sometimes, I mean, there's a strong risk of these AIOS kind of rotating or even going behind. So I would probably have done a 3-piece with an optic capture here, in spite of the fact that it was a multifocal. So it was kind of a very tight situation to do that, but I would probably still have gone with a 3-piece monofocal or whatever,
Yeah, thank you. Now we have Dr. Arvind's case, but I think somewhere is stuck between Telangana and conference coming back. It's a good video to be discussed by us, and it's a recorded video. Should I play his now? And then we watch it and then discuss it and then go on to the other videos. Okay, so that I don't miss out on that video.
Shall I start?
Start, yeah.
Greetings everyone. This was a case of penetrating corneal injury with incarceration of iris in the wound in the superiotemporal quadrant. So, routine X-ray and B-scan were done. We follow Birmingham Eye Trauma terminology system for assessment of prognosis in such cases. Surgery initiated by making a superior side cut, and uveal tissue was swiped from the wound by using blunt part of the instrument. One interrupted suture with 10-on nylon was taken using no-touch technique, and knot burial was done by gentle pulling and pushing movement. Now, one more side port incision and temporal main entrance incision were also made. Continuous curvilinear capsular access was made in maximum possible areas using Uttarata's forceps. Traumatic cataracts are soft only, so gentle hydrodissection was performed and removal initiated under bimanual irrigation and aspiration mode. Everything was going fine until at the superiotemporal quadrant, a posterior capsular rent was noticed. I am showing it in ultra slow motion once again for the educational purpose. At this point, phaco was switched to irrigation mode only, while first removing the aspiration cannula, followed by irrigation cannula. Cohesive viscoelastics were injected to keep the vitreous face behind, and then remaining cortical matter was removed gently. After this, anterior vitrectomy was performed diligently and thoroughly in every quadrant of anterior chamber where there was vitreous prolapse. This is the most important step for a successful outcome in such cases. I prefer low bottle height with vacuum of 150 to 200 and high cut rate for complete anterior vitrectomy. Some prefers IA cut mode also to tackle soft cortex and vitreous prolapse in the anterior chamber. Viscoelastic substances were again injected into the anterior chamber, and a 3-piece foldable intraocular lens was injected slowly, keeping in mind that first haptic opens over the anterior capsular margin, and then the second haptic was tugged in the ciliary sulcus, and surgeon made sure that the intraocular lens was well centered. OVD removal was done, followed by pushing 0.1 ml of intracameral preservative-free moxifloxacin. as there are chances of endophthalmitis in 2 out of 100 ocular trauma cases. Post-operatively, patient's best corrected visual acuity was 6/6. So, proper planning and prompt decisions helps in getting good results in such complicated cases. Thank you so very much.
Yeah. Going on to the discussion, Gaurav and Dr. Rohit and Ramurthy, I think this was again a video which has brought out some important points. Probably the preoperatively and OCT would have helped to know before you do a hydrodissection or for this particular case. And because this had a rhexis extension along with the corneal tear, the surgery was done at the same time. Otherwise, maybe you could have done a corneal tear repair alone, and if the anterior capsule was intact and there was a traumatic cataract, you could even wait and do it at a second sitting when you can do a proper biometry and do that is another way of addressing it. The question which I have is, and one other thing I heard, I think I wouldn't do it, is use of cohesive viscoelastic. I would use a dispersive viscoelastic when I want to compartmentalize the posterior capsule from the anterior capsule. I mean, posterior chamber from the anterior chamber. So I would prefer a dispersive viscoelastic in this particular case. So what are your comments on this? Dr. Gaurav?
I think you're very valid questions. And what I do feel is the way I noticed that the PCR happened was when, the instruments were withdrawn from the chamber and then it came up. So what I feel is that it probably happened because, as soon as there was shallowing of the chamber and that runaway, which was there to the periphery, which was limited only till the equator, probably, or anterior to the equator, it suddenly kind of progressed to the posterior capsule, and that's how the PCR happened. And probably if we had just been a little careful, and I mean, you probably don't expect this to happen, so we can't fault the surgeon with doing this, but the dictum would be in such a case is not to lose the chamber, maintain the chamber with infusion, fill it, replace it with viscoelastic before taking out your instruments, and we could have prevented this. And of course, all the other points that you mentioned about compartmentalization and choice of viscoelastic, they are very correct, and I would agree with those points. So is there anything else which I've missed amongst your questions, ma'am?
No, I think pre-op OCT, I'm sure that goes without saying.
Yes.
I mean, yeah, but in a soft cataract as this and not doing a hydrodissection makes it a little messier situation also too.
Absolutely.
Which has to be kept in mind.
Right.
Dr. Rohit or Ramurthy, anything to add? We go to the next video.
I think if you don't have the availability of OCT or you cannot visualize, hydrodissection in these cases should be avoided.
Yeah.
Definitely, because and you should start with the irrigation aspiration if you have to do a bimanual, and you have to start at the place farthest away from the place where the perforation was, so that you reach there at the. And the most important factor which Dr. Gaurav said was maintaining stable chamber settings. This is a very important factor which should be done, and the fluidics have not to be high, and rest everything is as you've already said.
Yes, Ramurthy?
No, in addition to use of dispersive viscoelastic, not taking out the instruments once you have a PCRN, but filling in with viscoelastic before doing that would have at least contained the PCR. But I think another important factor, I don't know whether it was edited out, he is not here, is that, at the end of any case where there's a PCR, I think it's today's world, it's important that we always check with diluted trabzone acetate. Even if you feel that there's no PCR, I mean, there's no anterior hyaloid face is intact and you're not done an anterior vitrectomy, after I place the intraocular lens in the bag or in the sulcus, I always make it a point to inject a little bit of trabzone acetate. And often I find that when you think that everything is perfect, there's a small strand which is hanging out, and then if you deal with it right at the time of the initial surgery itself, it takes care of so much pain later on.
Yeah. Anyway, I'm sure Dr. Arvind would see this video later, and thank you very much, Dr. Arvind, for a very educative video which you showed. We definitely missed your comments with these in this controversial situation. So we shall now go on to our next speaker, Dr. Praveen Dhanapal, who's the Director of the Cornea and External Eye Diseases and Refractive Surgical Services at Ratan Jyoti Netralaya, Gwalior. I should have had Dr. Purendra Bhasin as one more expert panel when I had you here. So let's look at his interesting set of videos. On to you, Dr. Praveen.
Sure. A very good evening to all of you. I'm sharing my screen, ma'am.
Yeah.
Can you see, ma'am?
No.
Yeah.
Yes. Yes.
So this was another routine cataract surgery for me. A nice access was done. So anterior chamber is filled with the viscoelastic. And now when I'm injecting the IOL, you can see the haptic is already partly outside because it was loaded by my assistant. I thought, no, this is not the right way. So I reloaded the IOL and now I'm injecting the IOL. So the leading haptic and the optic goes out very nicely. But notice the trailing haptic. It gets detached from the optic. So now I'm planning to bring out the optic out of the bag gently using the Sinski hook. It's out now. I am holding the optic using the grasper. Since the haptic was intact, I'm trying to reattach the same haptic here. And IOL is completely horizontal. You can see the optic is attached and forming the anterior chamber again with the OVD and gently reinserting the IOL into the bag. See, IOL is centered well now and OVD is removed. Surgery was uneventful and post-operatively patient was 6'6". And this is another case, a 67-year-old gentleman, aphakia post-VR surgery. He had undergone scleral fixated IOL, that is Yamane technique, in 2019. And post-op, he maintained best corrected visual acuity of 6'6". And 2 years later, he presented with endophthalmitis. And visual was PR accurate. We can see here inferiorly, the flange of the optic has eroded the conjunctiva. And this is the source of endophthalmitis. There's hypopyon in the anterior chamber and his IOP was 56 earlier. So we gave intravitreal vanco, Cefta and Deca after managing the IOP. Now the next plan of management is explantation of this IOL with repeat intravitreal vanco, Cefta and Deca. But the problem is exposed irregular flange which is eroding the conjunctiva. And we thought, why not address this issue? So now I'm holding the flange and slightly trying to exteriorize it, pulling it out gently with the microforceps. I'm trimming the irregular flange and recreating the flange using the Bowie cautery. The idea is to have a smooth and round flange here. And the flange is again tucked inside. Making the paracentesis incision and washing the anterior chamber of the exudates. Anterior chamber is formed and I'm again giving intravitreal antibiotics and steroids. And this is at 1 week follow-up. We can see the haptic is nicely fixated into the sclera and patient has got good visual acuity, and this is at 1 month post-op. Best corrected visual acuity is 6'6" again. The haptic C is now fixated into the sclera. This is my third and last case. This was again disenclaved iris claw intraocular lens. The surgery was done around more than 30 years ago. And we can see a large ECC wound with multiple stainless steel sutures here. His best corrected visual acuity was 6.9 and the specular counts were good. So our plan was to again re-enclavate the same IOL making the paracentesis incision and trying to assess the location or the enclavation part, site of re-enclavation, doing limited anterior vitrectomy. Now I'm holding the IOL with the micro grasper and with another micro rhexis forceps, I'm re-enclavating into the iris. Antechamber is washed off the on viscoelastics and case is reformed. This is post-operative day 1. We can see well-centered IOL, and this is at 1 month post-op. The patient regained 6/6 vision. Thank you.
Thank you very much, Dr. Praveen. That was a wonderful set of videos, and I felt very happy to watch them when I did. Now, some questions related to this, Dr. Rohit and Dr. Gaurav. How often have you tried inserting the haptic and you felt that it remained safe and fine and it was placed in the sulcus? And what is the way you can avoid this haptic erosion from happening if it has happened primarily? The way he managed it was fine, but the primary way how to deal with it, Dr. Gaurav?
Ma'am, I wanted to ask because maybe I missed a few seconds of the thing was how that patient presented with this, but what was the primary treatment which was done for the patient when this happened?
He cut the haptic.
No, I saw that how it was managed, but I was wondering that how the haptic found its way there and what was was it a Yamane which was done and then
Yes.
after that?
Yes, sir. It was a Yamane.
Also, it was a post Yamane.
Post Yamane only.
So the tunnel was already there and
yeah.
Right. So typically, I think if you've marked your, the exact 180 degrees and your, the tunnels, the direction of the tunnel and the length of the tunnel is adequate.
Yeah.
And also the choice of lens, frankly, because, if you have a IOL which has very long haptics, you may have to actually kind of trim them. Otherwise, they will produce a pressure and they will kind of, extrude like this. So the choice of IOL and all these things will go into ensuring that you've been able to prevent this kind of a thing. Yet it will still happen sometimes. And I was happy to see that it was managed and it worked, because I would have expected sometimes to have, probably because you shortened the haptic as well, and that may have been the reason for, that extrusion. And when once you shortened it and then you kind of treated it nicely with the cautery and may have pushed it back, so it stayed there. But I was concerned that again it might not just happen one more time, and then the conjunctiva will not usually heal very well in such cases because it's once it has been damaged and that area is now weak. So these few things are all possibilities, ma'am.
But again, in that particular case, which he showed very gracefully, but I wouldn't have enclavated it anteriorly after knowing the endothelial problems which can happen if you do an anterior enclavation. I would have still taken out that lens and done enclavated it posteriorly, iris fixation, retrofixation I would have done. And if it is a retrofixated iris which you want to disenclavate for whatever reason, any tip as to how it could be done? I think my mind says that if you take your spatula and push the optic of the iris behind take it behind the iris and push the optic behind and go in through the side port, and you should be able to disenclavate it. It might be a little tricky, but I think if there's enough viscoelastic in the eye. Dr. Gaurav or?
Ma'am, we have a power cut, so I'll just have to. I didn't get it. I was off for a few seconds. I agree with you when you say that. I would be reluctant to put that haptic back, but he managed it really well. I would have done a specular, and I would probably at 30 years post-op, I would have found the endothelium to be really bad, and I would have probably, done a posterior retrofixated iris claw or something here. Yet, it's if the cornea is great and everything's fine, he managed it really well. So,
So my
but I missed the second part of it.
If you need to disenclavate your iris, retrofixated iris clip lens, how would you do it?
I have done a couple of them because, sometimes while fixating, so I haven't had a big challenge in doing it. I use a dialer to do it or a hydrodissection cannula to do it. And usually it's fairly easy to do it once you know how the, enclavation and disenclavation works. But are you looking for some special pearl which I'm missing?
It just that I would push the haptic a little, optic, push it a little behind, and then
so
go
that you can
with
demarcate the area, right?
Demarcate,
Absolutely.
yeah, that's
Just
right.
like when you're trying to suture a haptic, which is behind the iris, you just push it up so that you can kind of see that thing through the iris. It's tenting it up. Here, you would just push it down a little bit so that you can see the exact area of intervention. And then I completely agree with that. That's an important pearl, ma'am.
In this case, his endothelial cell counts were absolutely good, sir, and very healthy.
Great.
So that,
Great. So then, of course,
that made me rethink my decision, and then I re-enclaved the same IOL.
Dr.
Dr. Chitra, can I ask one thing?
Yes. Who's that?
Rajesh.
Oh, Rajesh, Rajesh, you have to find yourself buried somewhere. This is the nth time you are ditching me now.
I'm so sorry. Actually, I was having a session again.
I know
that's
that.
why.
I know.
In a physical meeting somewhere.
I know.
So actually, I just want to ask a couple of things from Dr. Praveen. When I saw that iris claw lens, I mistaken. There was a faint whitish reflex coming from behind of the two margins of the capsule. Were the capsular margin present, Dr. Praveen?
No, sir. No, sir.
Maybe there was a large rent in the initial part for which the iris claw lens. Oh, okay. It was just my mistake then. The second thing I just want to ask that probably the conjunctiva, the tenons was atrophic in the case wherein there was you know, the Yamane technique that was done. In that case, whether the tenons was absolutely atrophic in that area.
Absolutely.
Because when the haptics were again pushed behind, again when the haptics were pushed behind, later on also in the post-op period, I could figure out that there was a little more of the haptic show, that bead that was showing through the conjunctiva.
Yes,
absolutely.
So the risk of, I mean, these patients will, please.
Yes,
these patients will require more meticulous follow-up because the risk of this haptic coming through the conjunctiva again is very high, because some of these cases wherein the tenons is absolutely atrophic, in such a case, such procedures may be a bit risky, but then yes, if you can do it well and follow up the patient more regularly, that will be better.
Yes.
So just a few points here, sir. This if, as you noted very nicely, the conjunctiva was almost scarred, and ideally this was not done by me. This was done by one of my colleagues, and this was not the ideal case to do Yamane technique. I would not consider doing Yamane technique where you have scarred conjunctiva. Post VR surgery, 360-degree peritomy was done, and there was a scarring. And second problem was because of the irregular haptic of the IOL. The flange was irregular, and that made it erode very early.
Yes.
Yeah.
Yes.
I would, one more thing that I would like to do in such a case, maybe we can press the the coagulated haptic from top so that it flattens a bit, rather than keeping an elevated bead-like end. I would flatten the tip by pressing it with an instrument so that it lies flat on the sclera.
Riveting the column.
Agree, sir.
Agree.
Yeah.
Agree on all your points, but you have to be with us. Otherwise,
Yes.
we'll be in trouble, Dr. Rajesh. So on to our next speaker. I'm so sorry that without realizing, Dr. Sanjeev Mohan, you are such a senior person and you had to wait for so long, but I'm sure you enjoyed all the discussions which came through, and it's one way of
No, Chitra, I'm not a senior person. I'm very junior, and I would love to be a junior person only. So I don't know if you want me to share the screen, I can do it, or if the video is up.
Yeah, whichever. You can share your screen, and Dr. Sanjeev Mohan is an amazing surgeon, and you should actually, I realized how amazing he is whenever I attended the TraumaCon conferences, whenever I was invited for that, and he's a very senior consultant at Venkateshwar Hospital, New Delhi, a cataract, cornea and refractive surgeon of great skill sets, and he's going to be showing his video. On to you, Dr. Sanjeev.
Can you see the screen?
Yes.
So this is just a single video I'm presenting with a lot of corneal opacity I saw the patient on the slit lamp and I thought that it should be quite simple. And I told my DNB students as well. So but the situation is always different on the table. And when I was doing that, I could hardly have any view. This is under the retroillumination, thanks to the Lumera eye, that you can manage somehow. So I dyed the capsule, which again, you cannot see very comfortably. And I was just going ahead practically blindly with my Rexus, the capsulotomy needle. So once I did the Rexus, I was a little more confident, because in these kind of cases where you don't really have a good view, you don't know what's going to happen. So I'd kept my extra capsular set ready. I'd kept my vitrectomy ready. I'd kept the anterior chamber lens ready. I normally don't do a direct chop. I'm a still old traditional guy where I make a trench and then I tend to divide the nucleus. I could hardly have any views. I tried to partly divide it, and I took a couple of pieces, and then you can see my hand is shaking. The phaco probe is shaking because I was trembling, because it was a private patient and you don't want to create any kind of complications. So once I got the hold of the nucleus, then it was a piece of cake for any one of our experienced surgeons. And I was able to remove the nucleus. But at all the time, my DNB student was assisting me. And I told them that you've got to be ready for any kind of uneventful complications on the table. Of course, once the cataract is removed, you can definitely have a very good flow under the retroillumination. And after that, of course, the lens was implanted simply. This is a slightly old video. So at that time, I didn't use an injector. And things went off nicely. But I just want to say that every day is not a Sunday. I mean to say I was lucky enough that I could get away, but I had to keep the things ready, mentally prepared. And also I had prepared the patient pre-operatively that I may or may not be able to the implant. And you may have some complication. I might have to put sutures or so. But by God's will, everything went off nicely. In one of the later conferences, I saw Dr. Noshe Shroff having a similar kind of a case with a lot of corneal opacity, and he used a chandelier light. And that's the time when it struck me that if you use a chandelier light, it works out very well. You have a good glow. And for my subsequent case, I did use chandelier light, and the things were much easier for me. So thank you for listening, and
Thank you, Dr. Sanjeev Mohan, for bringing out one more important thing. Is Dr. Praveen is there. Dr. Praveen, I wanted to ask this question with you. Now, Dr. Sanjeev Mohan has shown he has used Trypan Blue. He has not used endoilluminator in this case, but he has used it later. So that is also an understood fact. The other thing is, if in this particular case, would you think of doing a triple procedure, or would you think of doing a phaco only as was done by him?
Ma'am, I think I would see the status of the other eye.
Yeah.
First. I mean, what is the best corrected visual acuity? And there were multiple scars in the cornea. And if cataract was visually significant, I would rather first do cataract alone and then look for what is the outcome and then decide.
Yeah. And to all expert panel and Dr. Sanjeev Mohan too, if there was an inadvertent PCR has also occurred in this particular case, what would be your choice of IOL in this kind of an eye? Maybe more. There was some amount of clarity in the cornea in this particular case. Maybe it looked clearer after the cataract was removed. But what would be the secondary IOL you would plan to place if it's a PCR?
Well, if it's a PCR, at which stage it has happened, and if you can manage things, well, then obviously a glued IOL is the preferred IOL for my practice. As Dr. Sanjeev said, if the chandelier system would have helped, but had it been a mature cataract, then you would have used an endoilluminator for that matter. Retroillumination, he was using at times retroillumination, at times he was using the other illumination, and whenever he was using retroillumination, it was much better. Trypan blue staining is also a very important factor, which helps you see the capsule. So all said and done, coming back to the answer, a glued IOL for that matter, or it could have been implanted while doing the, if required, if you feel that corneal grafting would have been required, then it could have been done along with, or you could have done a glued IOL at this stage also.
Dr. Rajesh?
Sir, but why not multi-piece IOL in the sulcus?
Yeah,
if there's a tear and if there's a
Agree.
nice rexis.
Yeah.
Yeah, if the rexis is intact, then it goes without saying. If the rexis is not intact, then obviously it goes, and you're not sure whether the IOL which you are trying to put would be stable. In those conditions, yes, a glued IOL. But if the rexis is intact, then it goes without saying that you can put a three-piece IOL in the sulcus with capturing of the optic.
And Rajesh,
No,
would you
sir,
think
but
of
if I had a wrench and if the capsule was not intact with the way Dr. Rohitam Prakash is saying, I would have probably waited and visualized again the case and probably gone for a second stage of implant and probably reduce a less inflammation to the cornea, less damage to the cornea and to the endothelium. So that was my thought, what I had planned initially, which I told the patient as well.
Yeah. Rajesh?
Yeah.
What would you do?
In this condition?
If there's a PCR and you cannot place the lens in the sulcus.
See, if there's a rent and if there's a rent and I'm not sure about the anterior anterior capsule as well, in such a case, I would leave the patient AFK and evaluate in the post-op period and then decide regarding putting the lens, whether in the sulcus or glued or whatever. If there is any doubt, I would, in such a case, I would, if I have some facility of, putting a chandelier illumination or putting an endo-illuminator, which I do in many occasions, then if I'm able to see that the anterior capsule is there probably, then I would put a multi-piece lens. If there's too much of haze and I'm not sure, I will leave the patient AFK and maybe evaluate at a further date and then decide about the type of lens that I have to put. And if it's too much of hazy, then maybe I have to think of some corneal procedure as well.
Yes, thank you very much. Thanks a lot, Dr. Sanjeev. That was one more interesting situation you posed for more discussion and more learning for our audience. We shall now go on to our last speaker, Dr. Sugato Paul, and again, a very amazing surgeon and the chairman scientific committee of OSWB, and also senior consultant, or rather director of Sunetra Family Eye Care Center, West Bengal. So he is going to show us a very challenging case which he has very well dealt. On to you, Dr. Sugato Paul.
Am I audible and is my screen visible there?
Yes.
So,
yes.
Yeah, so this is a straightforward case. I started with non-challenging case. And as I do my surgery, basically I nick the anterior capsule with the keratom itself and put cohesive viscoelastic and go ahead and do the rexis and proceed for phaco. And I did the same thing. It's under topical anesthesia, young patient. And I was introducing injecting the cohesive viscoelastic. And if you notice, it's going in fine. And suddenly it came out of the locker. I was using a liver-leaf cannula, as you can see in the video. But in spite of that, it came out and injured. So what is the next step? So the first thing is to get a good view of the capsule, and I switched on the retroillumination. And this is what I can make out, that this is probably the extension. So in this situation, whether to convert or go ahead with phaco depends on the surgeon's expertise, grade of the nucleus, comorbidity, and also we have to decide the plane of the phaco. And if we are proceeding with phaco, few points we should remember, like minimal hydrodissection, then minimal lateral separation, then working away from the tear, doing a little bit of anterior planar phaco, maintaining the anterior chamber, look around for the wraparound sign as discussed by Rohit Om Prakash sir. Sorry for the mistake in the spelling here. And look for the vitreous pull-ups. And if it doesn't work out, should always have a plan B. And in this situation, there shouldn't be any ego. Ego should be thrown away, and you should think about the patient's safety. And in this case, whatever you do, you need a good access to the nucleus. So need a good opening in the capsule, and I decided to proceed with the phaco because the tear was slightly oblique, slightly away. It was not exactly underneath the incision. I decided to keep the same incision for the phaco instead of transfer to a perpendicular place, and gave a nick with the venous scissor and did a hemirhexis on the side. I'm doing for sitting on the top up, and so I got a temporal rhexis here, and then I proceeded with the nick on the other side with the needle and completed the rhexis there. The other half of the rhexis. So you have to be very slow, but after listening to the experts like Rohit Om Prakash sir, probably it will be better to do phaco with low parameters. And now while rotating the nucleus, it is better to use 2 Sinskey or 2 choppers so that you are not putting stress on the zonule. And during the phaco, again, minimum lateral separation. And if you can notice, I'm using the phaco tip and the chopper to rotate the nucleus so that no stress is put on the zonule. And again, while doing the chopper, the separation should be minimal. This is very important because the key point is not to put any stress on the zonule, or otherwise you might end up with wraparound tear or extension of the tear. So gentle chop into small pieces. I managed to get in this case. Otherwise, the option was to convert, but I was lucky on that day that I managed to get small chop. And once the chop was done, I managed to do the engulf all the emulsify all the small fragments. And all along, you have to keep an eye on the fluttering of the extension. And second thing is not to decompress your anterior chamber by taking away your phaco. Put viscoelastic so that the chamber is maintained. While doing the IA in this situation, transverse movement of the aspiration cannula helps. And then once you are sure you are not catching the capsule, get the cortex. Now the implant didn't go absolutely as my plan was. It's better to implant lens. It's not without rotating in the remaining portion of the bag, but in my case it was slightly off axis, but I managed to rotate it and then putting carpinol to get a round pupil and completed the case. Thank you very much.
Thank you very much. Can you hear me?
Yeah.
Yes.
There's some, I don't know, some electrical problem. The light's gone off, so I have not seen. But that was a wonderful video, Dr. Sugato. It's like keeping the best for the last. And there was, I mean, everything was so self-explanatory and every step of the way. But Dr. Rohit, I just wanted to ask you one question. In this kind of a case with the rhexis extension, would you like to chop all the pieces in the bag and then go on to remove pieces, or would you keep chopping piece by piece and then remove it? How would you want to do it in this kind of situation?
I think, first of all, we should congratulate Dr. Sugato for coming out with such an extraordinary display of surgery. Basically, the most important thing when you are doing all these things, as he was doing, you could see how he was chopping. You could see how his separational movements were.
Yeah.
The separational movements were in the direction of the tear. They were not perpendicular. Because if they are perpendicular, it has to be, you know, the direction of the separation is also very important. And the amount of separation you bring in, that is also very important. And once you separate, you can just emulsify it by bringing it in the supra, capsular area. That is another important thing. The bottle height has also to be, very well. Could have been better had you reduced the bottle height, because the low IOP pressure also helps in these situations. The direction of the, has to be in the direction which has it to be perpendicular, or has it to be in the same plane? That is the most important thing. It has to be it has to be 90 degrees from the area in which the axis of the extension of the tear is. So that is also a very important thing. And when you are using this phacoemulsification, one more important factor which has to be borne in mind is the site of incision preferably should not be in the line of the anterior capsular tear. If you can make it at some angle, maybe 90 degree, that would also be putting less stress on the anterior capsular tear which is there. So the question is, if we have to do, we should try to not put more pressure. So by reducing the height, reducing the separational forces, number two, direction is also very important. And you should try to do the emulsification supracapsularly. And when you're trying to rotate, try not to rotate much, because if you'll be rotating much, that also puts stress on the anterior capsular tear which has extended, which can make it a wraparound tear.
Yes, excellent. All the points very well brought out. Dr. Ramamurthy, Dr. Gaurav, anything? This was the last video, so we would be concluding after any.
Just as an add-on to what Rohit was saying, it's extremely important that the forces you apply for separation should be at 90 degrees to the direction of the runoff, and you do not want to stress in the direction of the runoff. And sometimes when you're doing a direct chopping, it's a little more difficult to control that. So sometimes what I prefer doing in these situations is to just go ahead and do a stop and chop technique, create a central crater, and especially this was not a very hard cataract. You hardly need any phaco energy, use low parameters, and rotate the nucleus at 90 degrees to the axis. For example, he had to chop obviously at the 3 o'clock meridian, but here I would rotate it so that my nucleus is directing from 6 o'clock to 12 o'clock, and make a very deep crater, and introduce 2 Sinskey hooks and just gently separate it so that I have 2 heminuclei, and then the soft nucleus I would prolapse them into the anterior chamber, and we usually do just a phaco aspiration of this lens matter, so stressing the capsule to the minimal extent. And this also helps, but obviously the case was very well dealt with. But sometimes when this rexis runoff is there, then I like to do a stop and chop technique where the direction of the separation of the heminucleus is at 90 degrees, and I get a better control that way.
Hydrodissection should also be, you should try not to make a vigorous hydrodissection. And the placement of the IOL in such situations should not be in the line. The haptics should not be in the line. While you are introducing, you should, the moment it goes in the bag, it should be, placed in such a way that it doesn't go in the axis, because that also at times, puts pressure, and that can also make it a wraparound. Ideally, if you can make it 90 degree to the axis of the tear, that makes it less traumatic to the probability of the flap extending and becoming a wraparound tear.
Can I ask 2 quick questions, please, for my improvement?
Yes.
One is, basically my incision was at 12 o'clock. My extension was from 2 o'clock to 8 o'clock-ish. So would you suggest to give a fresh incision so that I'm perpendicular from the extension?
Ideally, yes.
Okay.
Ideally, yes.
And second thing, would it have helped if I had put I was lucky, but probably would it have been better if I had put the IOL on the iris, positioned it, and then nudged it inside the bag, probably?
Absolutely correct.
Yeah.
And regarding one, sorry, yeah.
Yeah.
Go ahead. I mean, the way to ensure that you are at positioning is at 90 degrees, the intraocular lens, the optic haptic junction should ideally be at 90 degrees to the direction of the rexus extension. Because the haptics is almost all around. So you can't say that the haptics will not be there in the direction of the extension. But what we mean is that the optic haptic junction should be exactly opposite to the direction of the rexus runoff.
The curve of the haptic, the maximum curve where it goes to the equator, that should be at the axis. That should not be in the same axis.
Practically speaking, to answer your question, Dr. Sugato, I don't think I have never done this. At least, I mean, just because the rexus ran off, making a separate incision. Theoretically, it might sound right, but practically, I don't think most of us do that. And maybe the take home from this entire excellent presentation and the discussion is that we do not want to create any stress along the direction of the rexus runoff.
Yes.
I just wanted to add what Dr. Chitra had actually asked, that whether you would like to crack it completely into pieces and then do it, or so. I think what Dr. Ramamurthy sir said was that stop and chop would be a great way to go, but also the other way could be that if you're able to chop it easily, then remove one small fragment, like one small pie, and then you have enough space, and then crack all the others. And that ensures that your lateral forces of separation are minimized, because you've debulked the nucleus by at least 1/8 or 1/6 or whatever. So removing that small one pie is sometimes good, and then you can go on to chop the rest of the nucleus and then remove it.
Yes. So that was wonderful, Dr. Sugato. And I think
one can do cross chopping also in such patients, because when you're doing cross chopping, you don't need to rotate. So ideally, if you can avoid rotating much, that is the best situation. And when you are trying to rotate, you should not go beyond the tear, because if you go beyond the tear, that can also create a situation where it can become a wraparound tear. So cross chopping here, as we have learned in the posterior polar cataracts, wherein we don't rotate and we do the cross chopping, and that can also help in these patients, where you can avoid the concept of rotating it more. So minimal rotation, minimal separational movements. And as Dr. Gaurav added, this is also a nice thing, you take out one pie and then try to, and as Dr. Ramamurthy also said, separational forces, just pull it. Since it was a soft one, you could have pulled it, made it supracapsular, and completed the procedure.
Yeah. So thank you very much. And I think I'm sure all of us do feel that with the cluster of videos which we saw in the last 3 hours, it's been such a wide variety of cases which got discussed, and everybody put their life and soul into the talk. So thank you so much to my expert panel, Dr. Rohit, Dr. Ramamurthy, Dr. Gaurav, Dr. Rajesh, for being there, and amazing set of speakers. All of you, I'm not going to take individual names, but each video of yours was one to beat the other, and so much of learning, and it was definitely gave a lot of energy to this Sunday afternoon. I need to thank Harshul, who was to be my co-moderator, but was there for the earlier part. I need to thank my ARC team for always being there in the background to be supportive and help. And I need to thank Mr. Kripal and the entire AIOS team for all those SMSs which come to you, Sai and all the team of Numerotech, who ensured that these emails keep bombarding you along with my WhatsApp messages. I know, I actually imagine Gaurav shuddering when I start sending my WhatsApp. He knows going to shoot a number of them. And I actually smile at that moment, but I think that's the energy which ARC gives. Thank you very much, Dr. Anand Sethi and your entire team for being so supportive, last minute taking care. There was no glitch at all in sharing of the videos. Thank you so much for all of it. And finally, thanks a lot to all my dear watched it. And I'm sure some of you have missed some of it, can watch it later, because all of these are going to be loaded on the ARC website. Thank you very much. Thank you.
Thank you. Thank you very much.